Hi, I'm Dr. Tammy Nelson. Welcome to Integrative Sex and Couples Therapy, Level 1. Today's module is Assessing and Treating Sexual Issues. This is part 1 of a 6-part series. Today we're going to talk about healing the sexual space. You're going to be with me about 3 hours, and I'm going to show you a real case that I did with a couple. And we're going to talk about how to assess and treat sexual issues with individuals, men, women, and couples, including some direct interventions for sexual dysfunctions, desire issues. I'm going to teach you some skills to help couples communicate. And I'm going to show you what a solid theoretical foundation is and some therapeutic directives you can use if you have a couple today that you're working with. This does not qualify you to be a sex therapist or a sex and couples therapist. However, I will give you some information at the end of this course about how you can pursue your certification through me at the Integrative Sex and Couples Therapy Institute. Now, we're going to also talk about what skills you need to evaluate sexual issues in order to provide interventions and when you should refer out. You can use your own countertransference to decide what are the issues that you really don't want to work with, and that's totally fine as well. So we're going to talk about sex. We're going to talk a little bit about porn, about desire, about sexless marriage and how common it is in our society today. We'll talk a little bit about medications and the difference between pleasure and performance. And we'll look at that from an intersectional perspective. How does our culture create these issues? Is it the result of marriage in general? And then we'll get a little bit more granular and we'll talk about the medical issues from the anatomical perspective and what it means from a diagnostic psychological perspective, from an APA DSM view. And next time we meet in Module 2, I'm going to give you some real specific interventions for low desire or low sex or no sex marriages and relationships, and how to really work with pleasure disorders, even for people who've been through trauma and have a history of intermittent connections. And we'll talk more about that next time. And then in Module 3, I'm going to give you some real good couples counseling techniques. I think you can't be a sex therapist without knowing how to do good couples therapy, and you shouldn't be a couples therapist if you don't know how to work with sex, right? We're not working with roommates. This is important. And then in Module 4, we're going to talk about monogamy. We'll talk about the new monogamy, open monogamy, what it means to have an alternative form of relationship, and then also how do you work with affairs and post-infidelity and recovery from any kind of betrayal to your monogamy agreement. I'll give you the 3 phases of recovery and what to do in each of those phases with a couple or the third party or the fourth party or the outside partner in a relationship. And we'll talk about how to create a new vision going forward. In Module 5, we're going to talk about integrative therapy. So that includes therapeutic interventions, coaching. We'll talk a little bit more about race and intersectionality, LGBTQ treatment, body disorders, culturalism, eating disorders. And then in Module 6, we'll talk about alternative interventions and things like mindfulness, writing, journaling, narrative therapy. And we'll get a little bit more into how you as the therapist can create your own transformational life. Like, what are you here to do? What's your mission in all of this? And how can we focus your world to expand your own personal transformation in this work? And I want to help you with that and help you create your own vision for your own best work life. So let's get Let's get started for today on how to assess a couple and what to look for, and also where are we in our own views on how all this began and why are we talking about it? Because when psychotherapy first started, we weren't talking about sex in the way that we're talking about it today. So if you've ever taken a course with me before, you know I'm the author of several books, Getting the Sex You Want, which is a way to create a relationship for couples and hold the space to create more desire, more passion. The New Monogamy, which is a way to redefine your relationship after infidelity. My latest book, which is When You're the One Who Cheats, for the partner who's in the outside of the betrayal relationship. And the latest book, Integrative Sex and Couples Therapy, which is an edited book with many authors who integrate sex therapy and couples therapy. Some of you don't know that my first book is called What's Eating You, which was for eating disorders and body image. And so we're going to integrate all of those topics in this 6-module course so that you get the benefit of all those years of research and all of my clinical experience. I've been a therapist for about 30 years and in private practice for about 24 years. My oldest son is 23, and I think I started my private practice when I was before I was pregnant with him, so maybe 24 or 25 years at this point. So I'm going to share a lot of my clinical experience and some of my personal experience and show you how I work with couples directly. So let me just show you my theoretical background and what I believe is the core of the work that I do with couples. First of all, I think that we all at our root belief and value, our true nature, have erotic energy. And that eros energy is passion, it's aliveness. It's also the root of the word erotic. And that eros energy is the opposite of the death force. It's the opposite of thanatos energy. Thanatos is depression, it's addiction, it's hopelessness. Eros is the feeling of aliveness and hope and connection, and also it's at the root of our sexuality and the feeling of being in love with someone. And that's what a lot of your clients want when they come into your office. They want to feel alive. They want to feel passionate. They want to feel that connection to their partner, but also to their lives and in their lives. And this is an age-old dilemma. Tennessee Williams said the opposite of death is desire. The desire for aliveness, the desire for a partner, the desire to feel passion. And that in and of itself is totally okay and totally quote unquote normal. And that is the one question that your clients have when they come in to see you. It's an overarching, multicultural, ageless dilemma and a question for all of our clients and for all of us as therapists. Am I normal? Are my desires normal? Is what I want, is what I fantasize about, is what I crave, is that okay? And they're looking to you to be the arbiter of normal. They're looking to you as the professional, as the clinician, as the therapist, as the counselor, as the educator, to be the leveler of their sexual fantasies. And so let's use this as our baseline. Let's use this as our judge of what is normal. I'm going to tell you right now, there is no normal when it comes to sex therapy. Normal is what I say is basically a setting on the washing machine. It really doesn't mean anything because if you're in therapy with someone and they are the judge of what is normal, they're looking at normality through the lens of their own experience. So in other words, if you as the therapist are seeing someone who's coming in for low desire or lack of desire or lack of arousal, you may automatically see that person through your own lens and judge them by your level of desire. So if they say, oh my God, I only have sex like twice a day, there's something wrong with me, you might think, well, I only have sex twice a month, so I think you're perfectly fine, and maybe hypersexual. If you talk to someone who only has sex once a year and you have sex 3 times a week, you might think, wow, you really might be depressed, or there might be something wrong with you that you're so hyposexual. Hypo means low. And so instead of judging someone from our own lens, we start with that theoretical idea that there is no normal, because sex positivity means we accept people's desires, fantasies, and actions as long as they are not hurtful or dangerous to themselves or to others. And even around hurt and pain, we, at its core, think about things like consent. So we'll talk about that when we talk about sex therapy for low sex in Module 2. And what is consent and what does that mean? So I want to also bring up something that can be somewhat controversial in the world of therapy. One is, does therapy actually help or hurt? In the world of couples therapy, our training, and depending on you, if you're new to the world of therapy or if you've been around for a long time like I have, our training has been primarily based on emotional attachment and based on the level of affect in the room. In other words, there's been a feminization of couples counseling over the last 25 years, which means whoever is in the most amount of pain gets the most focus in a couples therapy session. Couples therapy is the hardest thing that you'll ever do, because people come into therapy way too late. They come in when they are feeling helpless and hopeless, all that Thanatos energy. They come in when they're there to drop their partner off on the way out the door, or to check off the box to say, well, we tried therapy. Or they come in because one partner is the driving force and the other partner is being dragged. And we know that the focus of couples therapy is to soothe the person who is primarily agitated or upset and who's been driving the relationship, and who was primarily the agitated part of the partnership. And yet we tend to have to work a little harder on the one who's conflict avoidant, or maybe a little quieter, or the minimizer. And in a heterosexual couple, particularly when we talk about low sex or sexless marriage, it's primarily been traditional for us to think in a cliched way that men come in and say, we're not having enough sex, and for women to come in and say, well, we're not having enough emotional connection. And if one partner wants to be emotionally connected before you have sex, and the other partner wants to have sex to be emotionally connected, a lot of times there's a standoff. And in therapy, we have historically focused on the emotional connection, hoping that the more emotionally connected you are, the more likelihood that you'll have sex. And frankly, I have found over the years that that's not necessarily true. That if you help a couple with their sex life, that the emotional component will many times work itself out. So this model of sex and couples therapy, or integrative therapy, is based on the idea that I have been teaching over the years, that there's really 2 parts of marriage or committed partnership. There's companionship, which is the day-to-day management of your life, your roommate relationship. Who walks the dog, who gets the pizza, How do you pay the mortgage? Do you hang out together and watch TV? How do you manage the kids? How do you co-parent? All that part of your relationship is your companionship. And a lot of couples are great roommates, and yet the second part of the relationship is the eroticism. And the eroticism is where you feel that aliveness and that passion and that in love part of the relationship. And yet we've been taught that if you just work on the companionship and work on your communication and decrease any conflict in that part of the relationship, then the erotic part will take care of itself. And that doesn't happen. In fact, you have to work as much, if not more, on the erotic aspect so that the companionship piece decreases in intensity, because you feel that in love, eros energy, and it leaks into the companionship. So couples really show up in the office for one of two reasons. One, there's been chronic neglect over time to the erotic part of the relationship. They've believed that they could work on their companionship, their day-to-day life, which they've been brought together to do. It's important work there: parenting, attachment, being friends, learning how to communicate, learning how to talk about important issues like money and pets. And yet they feel separate, and they feel loss, and they feel detachment. And by the time they get to therapy, they've tried many different things and nothing's worked. And there's a fear that that erotic energy is either dissipated or it's begun to be split off outside the relationship. Because remember, we're all erotic people. We all have that eros energy. If you're still alive, you still have it. So it's got to go somewhere. So the fear is, I'm about to split it off. I'm already splitting it off. My partner's splitting it off. It's going into an affair or pornography, or I'm just shutting it down, or I'm fantasizing about ending this relationship and going to somewhere else where somehow magically it will reappear, which sometimes it does. And if they're in therapy, they're really investing in figuring out how to bring that erotic energy back into the relationship. Now, the other reason that they come to therapy is that there's been a trauma to the erotic relationship. So the trauma might be an affair or a betrayal, or for some couples it's pornography or some kind of injury in that erotic arena. And less often is it to the companionship. Less often is it a roommate issue, and much more likely is it an erotic injury. You know, people don't cheat with someone because they clean the kitchen better. They cheat because there's a desire for something to shift in the erotic place. So we'll talk about that in Module 4 when we talk more about affairs. And in our culture today, we have a lot of interesting languaging around what is quote unquote normal, right? Whether you're in therapy, sitting in my office or one of your offices, or whether you're watching TV, or whether you're talking to your friends at the bar, you know, what is quote unquote normal? What are you supposed to be doing? The idea that the longer you're married, the less sex you have, the more you want to have an affair because that's hot, or the new language around open marriage is also intriguing given where our culture is today and how long we're living. The other language that's interesting if you're a therapist is what is sort of the hot dysfunction of today. Because as the DSM, which is the Diagnostic Statistical Manual, as that changes over the years, new diagnoses rise to the surface and reflect what's happening in our culture, what we believe is functional and, quote, normal, and what we believe is pathological, what doesn't fit into our society, what's not working for us in our relationships. And that's shifted over the years. And it's a reflection of what we can tolerate and what we're seeking, what we desire, what our vision is. 100 years ago, the number one diagnosis for women was hypoactive desire, which was a hyperactive desire, which was a highly sexualized desire, which was what we called back then hysteria. Right now, the most commonly diagnosed sexual dysfunction for women is hypoactive desire, which is low desire for women. Low desire for women. So a century ago, women were complaining of things like excessive vaginal lubrication, excessive sexual fantasies of someone other than their spouse, and these strange somatic experiences. And this was at a time in Victorian Vienna and places where upper middle class women had less responsibilities. They had less things to do in their home. There was more privilege in society where women were complaining about hysteria. And some of you know, because you've seen movies or read books, it's more common knowledge that they would seek help from medical doctors who would give them what was called then the treatment paroxysm. And it was a hand-manipulated orgasm. And some people believe that that was how the handheld vibrator was created. There's some controversy about that. But there is research that says that doctors would complain that their wrists would get tired and they would have like carpal tunnel syndrome because women would take up to 30 minutes to have an orgasm or paroxysm. And as you imagine, that women would, wait in line around the block for these appointments. But interestingly, back then, those feelings were common in women who had things like domestic help. They had people who could help them with their children. They had a paradigm where when they expressed symptoms of stress, they were told to do less things. So this was at a time when the early feminist writers were talking about the demise of women's responsibilities as the repression of women, so that you were told to read less or to do less important work, and that was actually a sort of passive-aggressive way of repressing the potential that women had. And so, this idea of desire or sexual feelings really was only something that arose for women that had the time to feel it. Women did not experience hysteria when they were working in the fields, or they had a bunch of children, or they were working in the factories, or they were the household help. They didn't complain about hysteria symptoms or excessive vaginal lubrication. So desire really becomes a paradigm that is around class and culture, and it's an intersectional issue. In different cultures, the same thing happens. So when women are homemakers or relegated to home with no jobs or responsibilities, it's almost like those labor forces have these restrictive beliefs around them. And as the vibrator in Vienna became something that women could own on their own, people were creating patents for these handheld vibrators, and they found their way into the United States. And between the turn of the century and the 1940s, you could buy a vibrator in the back of the Sears catalog. So this became sort of the gold rush of vibrators. And by the 1940s, when you could find those easily and women could purchase them on their own, there was no longer a recorded case of hysteria. And so you see, as the culture shifts around female sexuality, when women have control of their own desire and their own pleasure, and they can be in charge of their sexuality, then the pathology around sex changes. When they bring their sexuality and what they are in control of into their own private bedrooms, then it's no longer under the guise of the medical field or in the hands of their husbands. But then what we see is women going back into the workforce as the war takes their husbands and their sons, and women go into factory jobs and then go back into the workforce after the 50s. And now the rise of sexual empowerment and the advent of the pill and more freedom around the laws changing around child support and divorce, women becoming more independent and becoming more in control of their own marital life. Now, more women currently are employed than men. Women now have higher educations. Right now, currently, 2019, there are more single mothers than have ever been recorded before, according to Pew Social Graphics. And right now, more single mothers than married are predicted for up through the years 2040. And now we have this flip side of the same problem, that women are not focused on their own pleasure because they are tired, overworked, and overburdened. So now we have this idea of low desire for women as the number one diagnosis for sexual dysfunction. And when you ask women, why don't you want to have sex? What do you think is the number one cause for you? Their answer across the board is, I'm tired. I'm tired. So women today are in charge of their children, in charge of their jobs, in charge of their businesses, in charge of their homes, multitasking and multi-responsibility, and that leads to a feeling of exhaustion at the end of the day, and self-pleasure or pleasure in general or pleasure with a partner goes to the bottom of the list. So in modern sexual dysfunction, this is what we have. We have low desire for women, hyposexuality, and we have performance dysfunction for men. So all the sexual dysfunctions for men are around performance, arousal and erection and ejaculation dysfunction, which we'll talk about. And the third modern sexual dysfunction that we see is around hypersexuality, which is only diagnosed in men. It's usually around pornography or affairs, and it's usually called sex addiction, which is not a diagnosis, but we'll talk about that. There's usually like this psychopathology around male sexuality, and that they're doing too much, it's the wrong kind, they're doing it in the wrong way, and it's not emotionally connected. So going back to what I was talking about the emotionalization or the feminization of psychotherapy, now we have this pathology that therapy is pathologizing male sexuality, and the internet has created this burgeoning business around male sex and pathologizing that. And we'll talk about what came first and why is it doing that. So we do know that now 40% of women and 30% of men suffer from some kind of sexual dysfunction. So whether it falls in one of those categories will be determined by what we see, if it falls in an arousal category or a desire category. So desire and arousal are two different things. Desire is I feel like I'm into it and I want to do it. And arousal is my body can do it. My body can respond. It can be receptive, or it can step on the gas and do it itself upon demand. So those are different things, desire and arousal. 22% of women have low sexual desire, and 21% of men have premature ejaculation. Now, premature ejaculation is many times self-diagnosed, and we'll talk about that too, because the average length of or duration of intercourse before ejaculation is 4 minutes. Men come in to my office sometimes saying, you know, I'm really suffering from premature ejaculation. It only lasts like 10 minutes. And most women report that 10 minutes is plenty fine. And they're totally fine with it. What they're not fine with is if they don't have an orgasm first. So part of this is around good sexual education and having that information and having those numbers. It's also developmentally important to know where people are at different phases of their life, in different phases of their relationship, in different phases of their marriage, and different ages, and where they are sexually. So according to the Journal of Medical Association, low desire is the most common sexual problem in women at midlife, and they think like 70% of women report in midlife that they have low desire of some kind. We also know that 70% of women are working in midlife, and maybe higher if you include women who define themselves as working if they're staying home taking care of kids. So I don't know if that's correlation or causation, and I'm not sure how they define low desire either. And low desire can mean several different things. That you have lower desire for spontaneous sex than you did when you were younger, or then you have lower desire for a certain type of sex, or that you have lower desire for your current partner, or that you have less sexual fantasies, or that you've shut down your erotic energy. And that's not clear in that specific number of 70%. From a psychoanalytic model, Freud said we basically have two instincts, right? We have the instinct to survive, which is to seek food and water, and we have the instinct to have pleasure, which is basically have sex. So he said you basically want to eat and have sex, and that's pretty much it. We've made a joke about that as far as male-female issues, heterosexual issues, gay male issues versus straight male issues. And we joke around that that's really what men are about, to seek food and sex, but that's not true. Psychoanalytically, Freud said that's what all of our instincts are about as humans. And it really goes back to that sort of eros energy, that we seek pleasure, and pleasure is what helps us survive. That without the desire for pleasure, without the desire for intimacy or connection, or just to feel pleasure, then life becomes thanatos, becomes the death force, becomes depression, becomes put your head under the covers. Irving Yalom used to talk about that. The death force at the end of life is many times staved off by a huge rush of eroticism. It's the old men in their 90s chasing the nurses around in the nursing home, pinching them, because that erotic life force is trying to stave off death at the very end of life. And that instinct to seek pleasure, to seek pleasurable food, to seek sunsets, to be into the senses, is part of our instinctual nature. That we need to be surrounded by things that feel good on our skin. We need to be touched. That we need to be cuddled. That we need to be with someone who speaks kindly to us. All of our senses are instinctual. And that we will seek that out when that decreases in our relationship. So I'm going to ask you a question as a listener right now to this class. I want you to think about, how does your personal history with your own sexuality affect how you work with people? So how do you recall your first sexual experience? Was it a sensual, pleasurable experience? What about your current relationship, your current sexual relationship, or your last sexual relationship? How does that impact the lens through which you see your clients now, or through which you hope to see your clients if you're still in training? How does your history with growing up, seeing your parents' relationship? If you could take a minute now, you can put this video on pause and just write down anything that comes to mind about your own history with your own sexuality and how you think that might affect your work in this field of sex and couples therapy. And just take about 5 minutes to really understand where you're coming from in your own personal history. Okay, so we're back, and I hope you took the time to really examine how your own history with your sexuality affects your work. Because I really believe that this understanding what your mother thought about sex, how your father felt about sex, how your parents' relationship with each other affected you growing up, that is the lens through which you will see all of your clients, through which you will judge all of the work that you do. And this is incredibly important as we move deeper into some of our interventions. And just thinking about how we define sexuality. Our sexual identity is separate from our sexual function. So identity means how you identify your gender, your sexual orientation, and your intention. Like, you might be born into a male-identified body anatomically, but you don't identify necessarily as a male. Maybe you identify as a female, and yet you might be attracted to women, or you could be attracted to men, depending on your orientation. So there's a difference between sexual identity and sexual function. So what you are aroused by, how you orgasm, what you desire is your sexual function. And everyone's fantasies are different. And we'll talk more as we go through these modules about fantasy and what they mean. So identity, orientation, intention, desire, arousal, orgasm, all of those things are influenced by how you grew up and your experiences. And then your first sexual experience, your sexual experiences throughout your lifetime, and your current sexual experiences. And what you have learned given all of those experiences in your life. So my mother told me every experience she ever had in her life, every problem she ever had in her life was because of sex. And I think I was 6 years old when she told me that. So think about what I do now for a living. Like, I teach people as my mission in life that sex can be the solution and not the problem. And so there is a theory that we are all finishing off the missions of our parents in either a positive or a negative way. Like, whatever your mission was as a child, how is it connected to your parents' unfinished business? And how is your current relationship connected to what your parents would have wanted for themselves? Even if you purposely chose someone totally opposite of your parents. And how is your sex life connected to that? How is your sensuality connected to that? How does your desire and arousal discrepancy between you and your partner or partners connect to that? And do you think that you're quote-unquote normal in your sexuality compared to how you grew up? You know, there's no real consensus on what a average sexual experience is in a long-term committed partnership. We do know that married people have an average of 111 times per year sexual experience. So, you know, there's also studies that say that basically you have sex every 2 weeks if you've been married more than 7 years. But that may not be average or normal for you. Maybe you have sex twice a day. Maybe you have sex 3 times a week. I have a couple that's been married for 40 years. They have sex twice a day still. Another couple who has sex every 5 days. They've been married for 25 years. I see another couple who has been married for 30 years. They have sex about 3 times a year. But they go away for those weekends and they consider having sex like a whole weekend experience. And so how do you define your sexual relationship, and is it within the range that you desire? Because a lot of times couples will define their relationship as unsatisfying because it's not enough or not the right kind or not exciting or not often enough, but their partner will be satisfied. So who is the satisfied one in the relationship and who is dissatisfied? Are you both dissatisfied in the same amount and for the same reason? And how do we define a sexless relationship? So there are studies that say that 15 to 20% of couples are currently in a sexless relationship. And you can generalize that by saying that if you haven't had sex with each other in the past 6 months to a year, that's defined as a sexless relationship. And you can correct that, you can get back on track, but you do need help usually to do that, or something dramatic needs to change. So there's usually a problem there, something's going on. So there are 3 signs of a sexless marriage. 1, this is obvious, you're not having sex. 2, the thought of initiating sex makes you both anxious and avoidant. So it makes you anxious and you're kind of avoiding the whole topic. And 3, you don't touch each other in a sensual way. So you can be in a sexless marriage and still hold hands, walk the dog together, even cuddle on the couch, but not having sex, depending on how you define sex, it can be problematic for one or both of you. So if you're a heterosexual couple, it might mean penis and vagina sex. For other couples, a gay couple, intercourse can mean something else. You define your sexuality in your relationship and then think about the last time you had sex and decide, is it less than 6 months or a year since you've had your last sexual experience? And how do we define sexual dysfunction? So you can have a sexual relationship. It doesn't have to be a sexless or a no-sex marriage, but how do you define for couples if when they do have sex, it's a dysfunction? So what I'd like you to take away from today's course is the most basic assessment that I think you should use in all of your sessions is to ask people, when was the last time you had sex and how was it? Because remember, we're not working with roommates. We're working with people in erotic relationships. If they're in a couple and they're not just roommates literally, then they're there because they have some kind of erotic connection, or they, excuse me, were connected at some point erotically. They were attracted to each other, or they're worried that there's not enough attraction, or maybe they were never attracted enough to each other. There's some erotic piece there. And when you ask those two questions, you get a lot of information. When was the last time you had sex and how was it? So if you ask a couple, when was the last time you had sex and how was it? And they say, well, it was 6 months ago. And how was it? Well, it wasn't very successful. Then we have to ask, what does that mean? Sexual dysfunction means that there was a significant inability to respond or to experience pleasure. Like maybe one of you is into it, the other one isn't, or you want to be into it, but you can't respond, or you used to respond and now you're not. We need more information. So when you say not that great, like tell me more about what that means. And the more you open the conversation to the individual or the couple, the more it gives them permission to begin to talk about specifics. You don't need to know every detail of all the sexual dysfunctions in the DSM to begin a conversation with people that can help them to feel safe and comfortable to trust you to talk about this most personal and vibrant part of their relationship. You know, if you've only had a couple sessions or even one session with someone and you're asking them to trust you, hi, nice to meet you, my name is Dr. Tammy, can you please tell me the most personal and private and embarrassing and shameful part of your life? You have to expect a little bit of resistance to that. So you should have some basic knowledge of sexual dysfunction, but you don't need to have a PhD in sexology like I do, but you should have the potential for diagnosing and treating certain dysfunctions and discrepancies. So the sexual dysfunctions in the DSM-5 fall into certain categories. And I'm going to explain these to you, and then I'm going to show you a clip of a couple that I work with that came in for on the edge, low desire, sexless marriage, and I'll show you the clip and how I talk to them to make them feel comfortable and in a didactic way, using some sex ed, using a little bit of lecture and explanation, and then in the following two clips, I'll show you how I help them to dialogue with each other so that we could move forward in their therapy. So in the sexual dysfunctions in the DSM, there are three categories. There's sexual pain or some kind of disturbance. There's a desire or arousal category, and there's gender-specific sexual functions or dysfunction. So that would be like male-female specific problems. The most common dysfunctions are around male dysfunctions, most likely because they are the most often reported. And most likely as well because performance issues prevent family planning. The other reason that they're most likely, most commonly reported is because there's a pill to help men with erectile dysfunction. There is really no diagnostic psychopharmacological pill or remedy for women with low desire. Now we can help them with things like vaginal atrophy or dryness, hormonal issues, and some pain. But women don't think to go to the doctor to ask for a pink Viagra because there really isn't. There are some diagnosed medications now that have limited research about their efficacy. But still, the most commonly reported problems around sexual dysfunction are erectile dysfunction, premature ejaculation, a retarded ejaculation, which means it takes too long to ejaculate, and decreased sexual desire for men. The next category is dyspareunia and vaginal dryness for women. So dyspareunia is pain. And then the smallest amount of really problematic sexual problems or sexual function that people report is sexual dysfunction and I like comorbidity. So sexual dysfunction in alcohol-dependent populations, that happens to like almost 95% of people that are alcohol-dependent. Alcohol and erections don't really match. They don't go together very well. So if you have a comorbid alcohol dependency or some other drug problem, or if you're on any kind of SSRI or over-the-counter medication, most medications and drugs prescribed or recreational have sexual side effects. And so that's the other part of the reported sexual dysfunction is the interaction with medication, prescribed or otherwise. And so that's another part of your assessment that you could ask people, what medication are you taking? Blood pressure medication, cholesterol medication, Propecia for hair growth, even antihistamines. Antihistamines for women in particular, we don't think about the fact that they're designed to dry out your soft tissues. And that would include your vaginal tissues, internally and externally. And so it can lead to pain, dryness, thinning, and discomfort. And so that should be one of your assessment questions, like what medications are you taking? So So the specific protocol for assessment is the first thing you're going to do is ask those questions. When was the last time you had sex? How was it? What medications are you on? What's actually happening? What's actually happening when you say that there's some kind of dysfunctioning in your sex life? What's actually going on? Can you explain it? Like you say it's not going well, you're not happy. Can you tell me a little bit more about that? You do that before you treat, and then you integrate some of the treatment I'm going to talk about, and then you can reunite the couple. So it's assess, treat, integrate, and reunite. So we're going to assess for sexual difficulties, like what are they? And then also figure out what the partner issues are. So that's couples therapy. This is why I think integrating sex and couples therapy are so important. Like you can't do them separately. I just don't think that they work well unless you are working as a team with a sex therapist and a couples therapist. But I think you need both. And then it's okay to have individual sessions or to have individual therapists because each of the partners, gay, straight, whatever, will have vulnerability factors depending on what's going on with them. One might be at a different phase of their life. Another one might be, let's just say a young couple. They just had kids. She's post-childbirth, that postnatal phase of life where your hormones are crazy, you're breastfeeding. You're going to have a lot of different sexual issues and perhaps dysfunction or difficulty or pain or exhaustion than their partner might. And so they might have some vulnerability issues that can be treated biopsychosocially separately from their partner. There could be cultural factors. We don't look at the intercultural factors often enough, where we define, what are the gender roles that you have intuitively and implicitly assumed about what was going to happen here. We don't talk at all in therapy about what the assumption was around our long-term relationship roles. Did you think that it was just your job to always initiate sex, like that's what men do? Or did you implicitly assume that he was going to initiate sex because that's what turned you on? And it's hard as the female partner to say that because you don't really even have the language to describe it. You just know that that's true. Or do you feel rejected as the partner because your partner stopped initiating and you don't know how to say that either? Or do you feel like your female partner shouldn't be working because you should be home, she should be home taking care of the kids, and you should be out making the money, and then when you come home she should have dinner ready and she should look good, and she's overwhelmed and exhausted, and she can't handle the kids, and she's got postpartum depression, and that is not the gender role in your cultural expectation. That's not the way it was with your parents. And so you don't know how to make her happy, you don't know how to please her, and you're trying to have sex because that's the way you always pleased her in the past, and it's not working. And so what are those cultural, gender, implicit assumptions that you brought into the relationship that you didn't even think to talk about? Those are things that you can talk about in therapy. And what are the medical factors as well? I have one person who, he actually was in a car accident and broke one hip. And for a couple of years he was fine. He went to physical therapy, and then they stopped having sex. They came into couples therapy, and it had been like 6 months, 9 months, then 12 months, then 15 months. And she couldn't figure out what was happening. And I sent him back in for x-rays, and it turned out he had a hairline fracture on his hip that had not been diagnosed, and it had been missed throughout the physical therapy, and he had stopped having sex because it hurt, but he didn't know why. He thought it was just he wasn't stretching enough. And so assessing for all of those factors is part of taking good history, asking a lot of questions, but also including the partner in that discussion. So I'm going to show you a 15-minute cut of a session. It's the first session, or it's the beginning of a session of a sexless marriage, and it's going to show you like why people come in and how it works, and what I might say in the beginning, and how you too can not only assess but get a good idea of where the treatment should go after that. So have you guys ever been in therapy before? Ever seen a couples therapist or?
No.
No? Okay. So usually there's like a dragger and a draggee, and somebody that decided to come to therapy and somebody else that doesn't really want to be here as much. Is that true for you guys?
Yes, I think so.
Jen, you're laughing.
No, yeah. I mean, I never thought of it that way, but yeah, he wanted to go to therapy, and I was okay. I mean, I wasn't resistant to it, but I didn't suggest it. I mean, I think he's the one that brought it up.
Okay.
Yes.
All right. And so what would be the best use of your time today? Like, what's your goal for therapy today?
Well, it's kind of hard to talk about.
Yeah, well, it's always hard to talk about, first of all, your relationship, and I'm a sex therapist, so that makes it like doubly hard, right? Because you probably don't just sit around and talk about sex to strangers and about your relationship. And,
no.
Yeah. Do you guys ever talk about your sex life together?
No. But we have. I mean, we do. I think we're pretty open. We've known each other a long time. I think why I'm not going to put words into your mouth as to why
That's okay.
we're here. It's just, we don't have sex very much anymore. And, well, not anymore, but we just don't have sex a lot. And,
Yeah, that's true. I mean,
I still love him, and I think, I know he loves me. I'm not putting words in his mouth, and we have 2 great kids, and we have a lovely life, and we have fulfilling careers, but
it seems that I don't want to sound cliche, I guess, but in the beginning, it's like a whirlwind romance, and with all the sex and so forth, and then time flies, and over time, I guess you get into a routine. It's not become. I mean, I want to have sex, and it just seems like there's no coming together,
so to speak.
so to speak. One of us is always tired or doing something else, and it just seems to have got into a rut, like a accepting rut maybe, but not really. Well, it's okay. Well, we got our jobs and our kids and our routine, but I guess we both kind of noticed that something needed to change, and saying, "Hey, wow, it's been 15 years," and
well, it hasn't been 15 years since we've had sex.
Right.
But you've been together for
We've
15
been
years.
together for 15 years,
Okay.
and
yes.
So when was the last time you had sex? She's making a face.
This is August.
yeah, like last August.
Last one. So it's been about a year.
Has it?
It's surprising to you. It's been about a year?
Yeah, it is surprising, and that's not normal for me. So I feel strange acknowledging that or realizing it.
Yeah,
now.
realizing it. It's hard to just think about it.
Embarrassed?
It's embarrassing.
Wow.
Wow. And so...
But at the same time, we're not intimate with each other. It's not like...
Emotional bond.
Yeah, and we talk, and we're discussing things, and we talk in bed, and we do cuddle, and
Yeah.
so I feel like, I don't know.
It's the just sex.
It's the sex. So other parts of your relationship are good. You have a couple kids. It sounds
Yeah,
like
I mean-
in a lot of ways things are working, but it's the sex, like Jen says.
Yes.
So when did you have sex before last August? When was the time before that?
I think around,
Like once a month.
yeah. Well, okay, so last August, it was because we were on vacation, and I can remember when we did it, and the kids were gone, and we had the beach house, and we had the place to ourselves, and we were having fun, and
Yes.
we really enjoyed each other. And then, I don't know, I think that was August, it was the end of the summer, and I think like probably around our son's birthday, which was in like around Easter, I think. I remember because we went to my mom's, and she took the kids too, and they stayed with her, and I remember we had sex then too.
Okay.
But maybe
so-
that was like April, and then nothing again until,
August.
yeah.
So, but that's actually a good sign. So vacation sex is usually an indication of like when there's no stress, when there's nothing else to do, when you don't have a lot else going on, then if the sex is pretty good, then that means that when you can have sex and when there is nothing else in the way and the sex is pretty good, then that's a good sign.
And I know when we had sex in August, we were talking about we have to do this more.
All right, so that's also a
Especially
good
him.
sign.
Like, yeah.
That's also
yeah.
a good sign. So
Yeah.
there's a couple things I just want to say, after having talked to you guys for a little while and heard your stories and understood sort of what's going on in your relationship, it sounds like you have a really good companionship. You're getting along for the most part. Things are going well with your kids. You know, your kids are at that age, like middle school, high school. And you have some issues still with your kids where there's some high maintenance stuff, but not like it was when they were really little.
Right, no. They're more independent.
That's
Yeah,
true.
you're feeling some relief. So it sounds like you kind of woke up a little and looked at each other and said, okay, what are we going to do? And that makes total sense for where you are in your relationship around 15 years of marriage, because there's really two parts of a marriage. There's your companionship, which is like the everyday, walk the dog, take care of the kids, pay the mortgage. Like, that's what makes you roommates. And it sounds like that part is going okay. And that's the part that makes you feel like you love each other, things are good. But the whole other part of a marriage is eroticism. And the eroticism is the part that makes you feel in love. Like, I'm in love with my partner. I feel passion. I feel alive. And all this other stuff is important, but it's not really why we got together. Like, we got together for this. Yeah. And so sometimes people come in and they're like, I love my partner, but I'm not feeling in love with them. And I want this. And, you made a comment like, I guess this happens to everybody. It does to a certain extent, but it doesn't have to. And you don't have to accept the fact, well, I guess we've been married for a long time, so we're just not going to have that. I don't think that's true. I think you can have this. But we have this idea in our culture that if you just work on this and you work out all your stuff and you become closer and you learn how to communicate, that this will just happen, that you're going to come home from work and like sweep the dishes off the kitchen table and say, oh my God, take me now. Like, that's probably not going to happen.
No,
especially if you have
dishes.
Well, you have kids and jobs, and you work, and you're tired, and you're a little bit older. You're not going to have sex like you did when you were in your early 20s, and you shouldn't, right? We're going to move you to the next developmental level of your relationship. So you're going to have sex again, but you're going to have better sex and different sex. And we know you can have it because you've had it on vacation. But part of the problem is you're kind of waiting for it to just happen. Yeah. And for that desire to just hit. And the other piece is that desire and arousal are two different things. Like, desire is this feeling in your head, like, I want to do this, but arousal is the feeling in your body, like, I'm ready to do this. And just like you said before, when we had sex, in the middle of it, I was like, oh my God, why don't we do this more often? Probably because, especially for women need to feel aroused before they feel desire. So sometimes you have to go through many phases of arousal, and then you're like, ooh, I like this. So if you want to have sex with her on like Saturday, you have to start on Wednesday. So you have to like move things along for a couple days. Now,
he's not that well.
I haven't heard it put that way before, I guess.
Yeah.
I kind of look at it as spontaneity almost. Do I get mechanical? I'm like, okay, I got this time slot to have sex.
Yeah.
I don't know.
So let's talk about that. So a lot of people feel like, sex should be spontaneous when that desire hits or that arousal. But the bad news is that you're a little older now and you're not going to be spontaneous. Or you can be as spontaneous as you want, but you have to plan your spontaneity. So your goal is going to be to carve out some time for your erotic life. Everything else can be for your companionship. So my assignment for you is to have a sex date once a week. Now, for you guys, because you haven't had sex in a long time, I'm going to recommend that you don't have intercourse, like no penis and vagina intercourse, for like 6 weeks. And I'm going to tell you what to do for the next 6 weeks. But first of all, you have to decide that you're going to commit to a sex date once a week. It's got to have to be the same time every week. And you have to do it and show up, whether you feel like it or not, whether you're arguing, whether the kids are around, whether there's something better on Netflix. Like, you have to decide, like, this is really important for us
Yeah.
because we really want to make our marriage work, and we have to show up for each other. And if you can do that, then I can give you like assignments that you can do during that sex date. And it doesn't feel spontaneous at first because you have to plan it. But that gives you this anticipatory erotic feeling where you have time to look forward to it. So like, say it's on Saturday, every Saturday at 8 o'clock, or maybe it's in the morning or whatever's convenient. So by maybe the fourth week, on like Thursday, you start thinking about it. Even involuntarily, your body will start reacting to it, and you'll start going, Saturday's our sex date. I wonder if I should like shave my legs, or like, get a new massage oil or something. Like, you start anticipating it, and you start having a response. And it also takes away the pressure of the rest of the week to feel like, should I try to have sex? Should I initiate? Right. How come he isn't? How come she's not into it? Is she going to be mad? I feel guilty. It takes away all that because you're going to have sex on Saturday.
Because see, sometimes I feel I feel bad. Like, he wants to have sex and I just don't. And then he gets angry and he gets a little frustrated and I feel bad. And then I get angry and I get frustrated. And then we don't talk, and then, But I think it might be a good idea if we both commit to like a day, a time, and then what do we do? Like,
it goes both ways, though. I mean,
yeah.
Sometimes I feel guilty if I don't feel like I want to or ready, and then I feel like awful, like. Mm-hmm. Focus is on me, like, what's wrong with you? Mm-hmm. Or what's wrong with me?
Mm-hmm. Well, it's hard because you're the guy, so a lot of the pressure is on you because you have to perform. So a lot of, heterosexual sex especially is on put tab A into slot B and get to the finish line, which is usually male orgasm. Yeah. If you can't get there, we'll give you a pill, which I have nothing against. We can do that as well. But the idea is really not about being in the moment and just having pleasure for the sake of pleasure. It's sort of it's something else to put on the list. Mm-hmm. And I'm sure you guys have a lot of things to do on your to-do list. Mm-hmm. It sounds like you've been very busy the last couple of years.
Yeah.
Yes.
Mm-hmm. And this hasn't really been the thing that, you sort of crawl into bed and go, oh my God, thank God we have this at least to escape to. Mm-hmm. It's been like, no, let's hit the finish line at the end of the day and just collapse.
Yeah.
So we just saw a couple who talked about some of the issues in their relationship around what had become a sexless marriage. Now, in the very end of that clip, you saw something that may have indicated that that it might have been Mike who feels guilty about not initiating sex. So they talked about not having sex. We talked about the difference between companionship and eroticism. They said something interesting that, they were able to have sex on vacation, which is a good baseline. Vacation sex means that when there's no stress, when she's not tired from work, when the kids aren't around, when they have the freedom and there's no exhaustion, then the desire and the arousal is there. So that's a good baseline. So then we go back to that idea of when women have the freedom to explore pleasure, then the capacity is there. So we know then that there's not a medical issue, nor is there a sexual dysfunction that is something bigger or larger. However, we don't know about the relational piece. So I talked a little bit about the difference between desire and arousal, and I gave them an assignment to have a sex date. So when we talk about treatment, I'm going to tell you exactly how you can explain to them what a sex date is. You heard me talk about that a little bit in the tape. Now, he said that he felt guilty because he wasn't sure that he was initiating, nor was he showing up for the sex date as interested as he might have thought he would be. This is much more common than you might think or that people assume. It's almost a cliche that if there's low sex drive in a relationship, then it's usually the woman who doesn't want to have sex. However, it's much more common for a sexless marriage to be driven or caused by men having low or hypoactive sexual desire. So what we're going to do is switch the conceptual idea of sex as performance to sex as pleasure, so that there's not an onus or pressure on the male partner in a hetero or gay male relationship to be the one that has to drive the relationship, the sexual relationship, to get to the finish line, so that then and only then is it successful, and focus more on a feminine view of sex, which is about being in the moment and being in the pleasure, not having to get to that finish line in order to be successful. Because in the DSM, male hypoactive sexual disorder is defined as lack of or absence of sexual fantasies and lack of initiation. It's also defined as not having a response to a partner's desire. So male hypoactive sexual desire disorder can be several things. It can be situational, meaning they still have desire, but not for their current partner, which I think is interesting that it would even be diagnostic, because they don't define female sexual desire disorder as having anything to do with necessarily their current partner, but whatever. It can be acquired. It can begin after a period of normal functioning. In other words, they're good up until a certain point, and then it drops off. So we'll get back to that in a second. Or it could be lifelong, that they've always had no sexual desire. Could be they're asexual, or they have low testosterone. It could be something hormonal or medical. So a lifelong generalized hyposexual desire disorder means they've never had desire for any kind of stimulation. In other words, they've never been interested in masturbation, or never been interested in another partner, or this acquired low desire where they used to be really into it, now they're not so into it, not even in themselves, not into self-pleasure, or not even interested in another partner. So, and then there's acquired situational, and I find this interesting. So they're previously interested in their partner, but now they don't have any interest in this partner, but they have desire for stimulation with someone else. So this is defined as male hyposexual desire disorder, but it really sounds just like an affair. So as I said earlier, that one of the 3 sexual dysfunction components that we see in our culture today is this hypersexual area around male sexuality. And this is basically saying, it's a pathology, a diagnostic pathology for men to be attracted to someone other than their partner. This is not under female sexual desire disorder, by the way. So the etiology of desire issues for men, in other words, why do men stop wanting sex? Why did Mike begin to pull away from sex with Jen? Is it because he started to have some kind of sexual dysfunction? Barry McCarthy says that men stop having sex because they define their sexuality by 3 things: the capacity to get an erection upon demand, the ability to keep their erection for as long as they want, and the capacity to ejaculate across the room, which I think they get from porn, because that's not very realistic. So if they start having erectile dysfunction or premature ejaculation, they will pull back from initiating or stop initiating altogether, because that sexual dysfunction makes them afraid of feeling criticized, or they just have low self-esteem around it, that it creates performance anxiety. Or as when men age, their testosterone decreases after the age of 19. And if they don't have enough sex ed around what that might do or how to compensate for that, they might retreat and remove themselves from the relationship. Men sometimes don't understand that alcohol or stress or fatigue or excess carbs or trying to have sex at the wrong time of day will decrease their interest in sex. They also don't know sometimes that they need to use fantasy or change things up. They need to put work into that erotic part of the relationship. That there's this belief that sexual desire should be spontaneous, and it should come after a hard day at work when their partner's been with the kids all day. And that lack of interest signifies some kind of problem in the relationship or with them. And so they either turn to excessive use of porn, or they shut down sexually altogether. And porn is not necessarily a bad thing to stimulate desire and arousal if they bring it to their partner, but excessive use of porn indicates excessive masturbation. And if you're masturbating all day and then trying to get aroused for your partner, of course it's not going to work. And then it starts the anxiety cycle all over again. The most common male arousal disorder is erectile dysfunction, which means the inability to get an erection. And most commonly with men over 50, but it's anyone who, in any general situation, who has anxiety about getting an erection. So that anxiety cycle of, oh my God, I can't believe I didn't get an erection. So that happened to me last time, so I probably won't get one this time. And so now that I didn't get one this time, maybe it's not as hard as I was last time, so I probably won't do it again next time. That anxiety cycle is the most common arousal disorder, which is why things like Viagra, Levitra, or Cialis actually work well, because they drive the blood flow to the extremities. They don't create desire, but they do create a physiological arousal response, which can decrease some of the anxiety, so that next time it feels like, oh, thank God, like that worked well last time. The one thing I do want to say about them is that if you eat rich food or drink a lot of wine, at the same time that you take one of those inhibitors, then the pills usually don't work as well, or they are prevented from full efficacy. So you have to be aware and make sure you tell people that if it doesn't work, or if it's only 80% efficient, then it may not be you, it could be what you ate. So you can't go out and have a nice big dinner and think that that's going to be your date night. And premature ejaculation, first of all, has no physiological cause. So sometimes the inability to get an erection, an erectile disorder, can be caused not just by anxiety, but it can also be caused by medication, psychotropic medication, some of the medications we talked about before, blood pressure, cholesterol, heart medication, Propecia, over-the-counter antihistamines. Almost all medication has some kind of sexual side effect. It can prevent or delay erection and also decrease desire and arousal. But also, I just spoke to a cardiologist who said that if there's an abrupt change in the capacity for erection, it can also be a sign of cardiac distress, and that there might be an incident about to happen that's common in some men. So it might be really important to send someone to a referral to a cardiologist to get checked out if something has changed. And also it's important to go to a urologist to have the prostate checked, because if you have swelling of a prostate, it can affect erection and it can affect ejaculation, and you want to make sure you get checked for prostate cancer, or just a swelling of a prostate, which happens more often over the age of 50. Going back to premature ejaculation, it's very rarely caused by things like prostate issues or medication. In fact, sometimes psychiatrists will prescribe, or a urologist will prescribe, SSRIs or other medication to delay ejaculation if premature ejaculation is really a problem. Viagra, Cialis, and Levitra will not affect how long it takes you to ejaculate. But a lot of times, anxiety does affect the length of time a man can last. The best thing for men who are concerned with how long they last is sex ed, that they don't learn good sexual capacity from pornography, and they're probably not going to learn it from the internet unless they go on to a good sex ed or sex therapy website, or read a good book on sex therapy. But most likely premature ejaculation is a habit. Men learn about ejaculation through masturbation, usually when they're young, when they're hiding it, when they're afraid someone's going to walk in the room, when they don't want to get caught, they don't want their parents walking in on them. So they're masturbating rapidly, quickly, illicitly, in a hidden way, in kind of a guilty, rapid way. So trying to do it fast before they get caught. And that creates this neurological pathway in their brain that says, okay, do it quick before somebody walks in. And that early neurological pathway is now connected to ejaculation. So you have to reteach yourself and give yourself a new habit of how to learn to ejaculate after a longer period of time. So one of the skill sets is to not distract yourself, like they used to say, just think about baseball and then you won't ejaculate too soon. It's actually the opposite. You have to think more about what you're actually feeling. You have to use mindfulness techniques to be super aware of when you get closer to the edge of ejaculatory inevitability, so that you can practice pulling yourself back. So one good skill that you can tell people is, there's a exercise called stop-start, where you masturbate almost to the point of ejaculatory inevitability, and then you stop and pull back, start again, pull back, start again and pull back, and then let yourself ejaculate. That's only helpful if you practice it. So a couple can do it together, or a man can do it on his own. And that increases positive experiences and increases the experience for the couple if they do it together. Now, if pornography is part of someone's regulatory system, in other words, they've been looking at it since the age of 13, and by the way, more than half of all women have watched porn as well. And we have to define pornography because this is a Klimt drawing, but the idea that erotic imagery can turn people on has been around for a long time. And some people use pornography as a way to create variety in their life, as a way to maintain monogamy so they don't go outside of their relationship. But for other people, it creates a threat to their monogamy agreement if it's not open and agreed upon and explicit. It can feel secret instead of private. And so it has to be an explicitly agreed upon thing that it's going to be private. And is it the imagery that's interfering in the relationship, or is it the masturbation? So we'll talk more about that in Module 4. But I just wanted to, in very brief description, define pornography. That people in general have a paradigmatic erotic scenario, the understanding of which will enable us to understand the person. So in other words, once you understand what turns someone on, you understand what's at the core of that person's anxieties and desires. And Jack Morin said fantasies are a way to rework a problem from childhood. And the way that I describe fantasies are that they're a way to work through your deepest anxieties and fears. In other words, if you're watching this video right now and you're thinking, I have to listen to everything she says because I know there's a quiz at the end in order to get my CEs, and you're anxious, you may fantasize about going to the beach instead and putting your feet in the sand and watching the waves because it's a way to escape from your anxiety. So fantasies are always a way of healing from your fears. And we'll talk about that next time in Module 2. But there's a famous quote from Supreme Court Justice Potter Stewart who said, "I don't know what porn is, but I know it when I see it." So for a couple, when porn becomes an issue in an otherwise sexless marriage, I have another couple where they came in, I asked them, when was the last time you had sex and how was it? They said it had been 2 years, but she had walked in on him. It's a heterosexual couple. She had walked in on him looking at pornography, and he was looking at pornography of men having sex with men. And he said, well, it doesn't really count because I'm a straight man, and this is not anyone that I would actually have a relationship with, so it's no threat to you. And besides, I've been doing this since I was like 12. And she said, yeah, but I thought that when we got married, you wouldn't look at porn anymore. And he said, well, I never agreed to that, and we never talked about it, and this is what I do for me. And she is convinced that he's gay because he's get turned on by gay porn, and he's convinced that this has nothing to do with her, and it's compartmentalized, and she's wondering if it's the cause of their sexless relationship. So let's take a minute, if you're watching this video, and take out a piece of paper, and I want you to think about a couple or a client that you have, or someone you've worked with in the past, or someone that I've mentioned or talked about, or perhaps Mike and Jen that you saw on the video. And I want you to imagine sitting in the room with them. Maybe it's someone that's struggling with pornography or struggling with one of these sexual dysfunctions that we've talked about, or low sex or sexless marriage, gay, straight, trans. Imagine sitting with them, or a poly, maybe it's several people in the room. Imagine sitting with them in the room and just close your eyes for a minute. And how does it feel to sit with them? How does it feel to sit with this client or this couple? What does it feel like in your body? What is the emotion in the room? Try to identify for yourself what's happening. And just make a couple notes. What does it feel like to sit with them? As you're thinking of what it feels like to sit with this client or this couple, notice the emotions, notice the feelings in your body, and what information does this give you? Because most likely, this information is not about you. It's about them. It's giving you the key to understanding this client or this couple that you have been looking for. This is countertransference magic. So I'll give you an example. I have a couple who I've been seeing for a long time, and I really like them, but every Thursday I would get super anxious and decide, I should just go home early, I should cancel them. They were a full fee paying couple, they liked being there, they were compliant, they did all their homework, they always dialogue like I asked them, but there was something about them that just made me totally anxious. And I finally, I sat with that feeling, and I found myself tripping over my words, and I couldn't decide what to say, and I would feel frozen, and that, as you can see, that's not really like me. And I finally said to them in a session, I'm not sure why, but I can feel my anxiety growing as we sit here. And she said, oh, I'm so glad you said that, because I'm so anxious coming here. I can't stand being here. And he said, yeah, I don't want to come here either. I'm done with this. And that brought up a whole conversation around her lack of interest And she really didn't want to have sex with him anymore. They had been together for like 40 years. And she said that when she had sex with him, it was painful. He had a large penis. She didn't like to have intercourse. She wasn't having orgasms. She was afraid to tell him. It came out 2 sessions later that she'd been faking orgasms for like 35 years. And he was hurt and cried, and my anxiety was gone. It was like they'd been holding these secrets throughout their whole marriage, and they had been coming to therapy to try to work through whatever was going on with them, but they weren't able to talk about it. That anxiety was just holding everything so tightly, and they couldn't repair anything without opening that door. And so that anxiety was not about me, it was about them. So think about what you're feeling when you're with this couple or this client, and how does that indicate perhaps a doorway for you to get more information about this couple. We talked about men and their sexual dysfunction and some of the ways that it can find its way into creating the cause of low sex or sexless relationship, and how do you work with a couple when you're assessing that, and how do you treat some of that? What's the biopsychosocial piece there? For women in sexual dysfunction, more than 40% of women 18 to 50 experience sexual dysfunction. So that means a lack of interest. That's the most common that we talked about. But there's also arousal disorder, so they might have desire, but they can't get aroused. So they can't respond with like orgasm, or they can't get to the point where they could have comfortable intercourse. And there's many causes of this. One, I would always ask for where they are hormonally, so pre or postnatal, or peri or post-menopausal, or if there's been any kind of surgery or change in their hormonal status, any recent illness or surgery, or if they're on any medication. All of that can create problems in arousal. It could also be linked to anxiety, stress, or a history of sexual abuse. And also body image. Most women at some point have had some body image issues throughout their lifetime, and that affects how they allow themselves to relax into the sexual experience in order to get aroused, in order to have an orgasm. You can't have an orgasm biologically, anatomically, if you're not relaxed. It's virtually impossible. So if you have what's called spectatoring, where you leave your body during sex because you're looking down and judging yourself, going, oh my God, I can't believe I look like that, then it's very hard to be in your body and be present to have an orgasm. So you can have pleasurable sex, you can have a pleasurable or pleasant experience, but an orgasmic disorder means that you aren't getting enough sexual arousal or ongoing stimulation, either from your partner, through your partner stimulation, or even on your own, through your own manual stimulation or through a vibrator. Now, sometimes that happens if people have a genital pelvic pain or penetration disorder. In other words, they have some kind of pain disorder. Vaginismus is when there's a contraction of the muscle that sometimes is to the point where literally you can't get a Q-tip inside of the vagina or vaginal opening, or even the introitus, which is the very, very outside opening, without severe pain. So that can be actually caused by repeated infections, vaginal infections, or UTIs, or some kind of trauma, both emotional or physical. And sometimes it's a relational issue. Sometimes it just closes down and says, I'm not getting in there. But it's a real thing, and it can be very difficult to treat with gynecological intervention, because if you can't get anything done in an exam, because it's very traumatic and painful, sometimes you can bring in a pelvic floor therapist, and that's helpful. We used to say that people had sexual aversion disorder, or we used to say, people were frigid. We don't use those words anymore. They're condescending and pathologizing. But we do say that people who have orgasmic disorder or anorgasmia, that's different than hypoactive sexual desire disorder. But I want to just touch for a minute on just the characterological history of these terms, because we also don't say sexual anorexia anymore, although that was a term that was used in the sex addiction world. So it was described as like this pathological loss of appetite, or sphere of intimacy. But interestingly, they don't describe men who have a loss of appetite for sex as sexual anorexics, only women. So it's most often used to describe women who are, quote, frigid or what we call today hypoactive sexual desire. And I think that's interesting in a culture where women are most often diagnosed as anorexic, where you have a failure to maintain a body weight of at least 85% of your ideal weight. And it's characterized by this distortion in body image. And sexual anorexia is actually an intersectional term that was used to describe a crisis in black sexual politics, like in the late 90s. And it was about the repression of women. And so when we think about how people describe low sex and low sexual desire in women and anorexia and sexual anorexia, the pathology around the lack of desire, the starvation, is really around power. That women historically have only had control over a very small aspect of their lives, their body, what they put into their mouth and what they didn't put into their mouth, what they let into their body or what they didn't let into their body. And so when we talk about sex and food and eating disorders and what women have traditionally had power over and in and control over and in the field of psychotherapy and psychopolitics, these are the areas that traditionally have come up. So I want to talk about this from a feminist perspective as we go on, from our intersectionality perspective when we talk about gender, when we talk about politics, when we talk about gender roles, when we talk about people of color, when we talk about our cultural background. And keep this in mind when we talk about things like sex addiction, which is primarily a diagnosis of men. We don't talk about sexual bulimia, where people binge on sex. And we don't use sexual addiction in the DSM as a diagnosis either. So as we pathologize our diagnostic criteria, I would like to use those pathologizing terms as purely a reflection of our culture and where we are today. As I talked about in the very beginning, diagnoses around sexuality and around relationships are a reflection of where we are in our work today as therapists and where we are in our culture. And when we come back from our break, we're going to focus more on what is actually happening in science instead of just a reflection of culture and what's good, bad, and normal. And we'll talk about some brain studies that have been done in women with hyposexual desire disorder and what is happening neurologically. And then I'll show you a little bit more of Mike and Jen, and we'll talk about treatment and integration. Hi, this is Dr. Tammy Nelson, and welcome back to Module 1. This is part 2 of assessing and treating sexual issues. So we've been learning ways to define sex therapy and relationship therapy and how they apply to our treatment outcomes. And we've been learning how sexual desire issues and therapy at its roots, its background, cultural issues, history, apply to treatment strategies. I've been showing you some effective tools you can use, and we've been exploring our own countertransference to talk about these conflicts around sex and relationships in order to measure how we can be more effective with our clients. And we're going to learn more about assessing a couple for desire discrepancy and talk about the cause and effects of these sexual dysfunctions that we've been talking about specifically, and apply some treatment interventions so we can get some positive outcomes for the clients that we treat. We've really talked about some of the cultural influences and the diagnostic criteria of what might be causing some of these sexual problems in relationships. But I want to give you a little bit of neurological background. I'm going to talk about one brain study that they've done where they compared the brain activation patterns of women that have been diagnosed with hypoactive sexual desire disorder to people that have not had that diagnosis. So this is a small study. It's only 16 women diagnosed with HSDD and 20 control subjects. But what they did is they showed women erotic videos and interspersed with women doing sporting events. And they interspersed those video footages with flowers, mountains, oceans. And they did that so that they could see how their brains were activated, and then the calming visuals would bring their brains to a resting state. And then they put them in an fMRI machine, and they looked at what part of their brains would get aroused or were affected by the visuals. They also had the women report subjective levels of sexual arousal. So did they feel sexually aroused by watching the erotic video? And then they also measured their objective genital arousal. So did it drive blood flow to their genitals? Did they have any excessive lubrication? Did they have clitoral stimulation? And they found that there was a jump in 3 areas of their brain in the women that had hyposexual desire when they were shown the erotic clips. 2 of the areas where they had increased activity, the medial frontal gyrus and the right inferior frontal gyrus, I think I'm saying that right, have been associated with a heightened attention to your own and someone else's mental states. So keep that in mind. So you're paying attention to your own and someone else's thoughts, where are you? What are you thinking of? How are you feeling? How am I thinking? What am I feeling? What's going on with me? So you're super tuned into yourself and someone else. And the suppression of your own emotional response. So all that's happening, but I don't know how I'm feeling about it. So I'm super tuned into what's going on here, but I'm not letting myself have an emotional response oh, that feels good, or oh, I feel good. So one of the main differences between the women that are diagnosed with hyposexual desire disorder and the controls, the ones that weren't, was that there's this activation in those regions that's around self-monitoring. So that might be lowering their ability to respond to that erotic stimuli. In other words, there's an increased attention to their own responses to the erotic stimuli. Oh my God, am I getting turned on? Am I taking too long? Am I doing the right thing? Should I be doing something else? We call that spectatoring, getting out of your body and looking down and going, maybe I'm taking too long. maybe he's trying so hard, maybe I should fake my orgasm. 80% of women fake their orgasm because they feel like maybe I don't know how to express what I really want. Maybe I don't know how to share with my partner this isn't working for me. Maybe go a little to the left or a little to the right, or stop or slow down or not so hard. Or so instead, because they're protecting their own ego and their partners, they fake an orgasm to move the experience along. And so that hyper awareness of their partner, like, oh, I hope they're okay, is actually taking them out of the sexual experience. And so the increased activation in that part of their brain may correlate with an ability among women with no sexual dysfunction compared with the other women to focus on emotional memories. So women that in the control group can actually respond emotionally in those moments, whereas the other women couldn't. So, in other words, they could feel something and go, all right, let me just think about how this feels. Let me just be in this moment, and I can have what they said were an emotional memory. I hear that, and what I make up that they were doing is that they were having a fantasy. They were remembering a positive experience that they had had that is being triggered by this sexual experience. So maybe they're remembering another time when they had an orgasm, or another time when they saw something similar that was pleasurable, or they experienced some type of pleasure that was related to this sexual event. So in other words, they could let go and fantasize and think of something that feels good. Or they could have a pleasant emotional experience with the person that they're with, instead of being in that judgmental place that says, I wonder what they're thinking. I wonder if I'm doing it right. I wonder if they're thinking something about me. And they could just be in that moment emotionally with that partner. Now, keep in mind, correlation is not cause and effect. So the study could be saying that too much attention causes inhibition of desire, or the lack of desire in that situation makes you self-conscious. Like, oh my God, I'm not really feeling it. And so now I'm in my head, versus being in your head makes you not feel desire. So it's hard to know what comes first. That being said, there is a neurological component here. So in other words, there is a cognitive distortion that happens, and there's also an emotional piece, and then there's the part about being in your body. So there's the narrative that your head tells you, like what is happening. What's the story that I'm telling myself about what's happening? What's the story I'm bringing into the bed with me from my past and my history? And then what's the emotional piece, my emotional reaction, my emotional response? How am I getting triggered by this piece? Am I trying to climb over the resentment that I have from 2 days ago when we had an argument? Or is this reminding me of something that happened in college because the way that he's touching me, when I'm having a response in that way? Or am I able to let go of that and open up to imagination, which is also in the emotional space? And what's happening in the body? So how is your body responding to pleasure? So in the next module, we'll talk more about how to sink into pleasure for the sake of pleasure, which Mike and Jen in the video that we saw earlier were beginning to talk about. In the next video clip that I'm going to show you, I guide the couple to talk in an appreciation dialogue. So when you begin to change your sex life, you don't start off with what's wrong, what's not working, what you're not getting enough of, how your partner's not responding well enough. So in other words, you don't say, I hate it when you go to the left. You say, I love it when you go to the right. So the beginning of couples therapy around sexual issues and sexual dysfunction or low desire is to teach them to speak in a way that shows appreciation instead of criticism. And it's really a secret to couples therapy is to teach the couple that you always get more of what you appreciate. And to begin that dialogue puts the responsibility back on the couple to begin their change and their growth and their healing, and takes all the responsibility off of the therapist, so that you don't have to have the responsibility to do individual therapy with both partners. You're actually teaching them a skill set that they can bring home, that then you can begin to expand on throughout the sessions, and that they can use at home as homework. So this is the first dialogue that I would do with them. It's from an Imago relationship therapy dialogue called the Appreciation Dialogue, where I teach them to mirror each other and share with each other something they appreciate. So I teach them 3 appreciations. I expand on that in my own conceptual dialogue in Getting the Sex You Want, to integrate sex therapy with Imago relationship therapy. So I'm going to show you how I do that with this couple. And then in this video, there is a description around fantasy and how I begin to talk to them about how to integrate this idea of fantasy and what you long for, and how sometimes that erotic energy gets split off outside the relationship. We have this cultural miasma around good girl, bad girl longing. And in the third video, which I'll show you in a little bit later, we'll talk about how we manage that in the intervention to get a more positive outcome. So this next clip around Mike and Jen is around sexless marriage, and it is about 22 minutes.
Like, I love Mike. I think he's a great guy, and he's a great dad, and he's a great provider, and all those goofy things that, you know, not goofy, but just those, like you said, cliche things. You are all those things. And I'm not, I don't want our relationship to end, or like, you know, I just feel that there is, like, I know that I am not, I don't know, maybe I have an issue or something. I'm just not into it anymore. Like, but yet when we're doing it and we're having sex and he has an orgasm, I have an orgasm, like, when it's over, I'm like, this is fantastic. I can't, you know, and I just feel this connection with him, and I want to do it again and all that. But like, ramping it up is just like, it just feels like such an effort. And I feel bad about that. And I don't, I mean, I feel good about myself. I feel attractive for my age and all those things. And I know he loves me and likes what he's looking at. But it's just about getting all that stuff out of the way to make time for the two of us.
Yeah.
I get that ramping up, so to speak, and the procedure and the
Procedure.
the sensitivity. I mean, the sensual part of it. You know,
Takes time.
I'm all about that, and I'm at a loss for words.
So
it's sort of,
it makes sense, though. Let me ask you a question. So a lot of times for women, the thing that prevents them from getting to that place where they can ramp up is either the stress, because you have to be able to relax in order to feel pleasure. Like stress and pleasure just don't go together, really, because you have to anatomically relax in order to have an orgasm. So you have to actually be relaxed in order to be in that place. And so if you're totally stressed, you can't go from totally stressed to like, okay, I'm into this. So you do need that time to ramp up, as you said, or even ramp down, is what I call it. And the other reason that sometimes it's hard is sometimes it's difficult to climb over a giant pile of resentment in the middle of the bed. And
I get it.
you get that? So there might be one of those, like that pillow in the middle,
can
the middle of you.
The big resentment.
Is that the big pillow of resentment?
I don't know.
Comfort, yeah. And so sometimes people need to feel emotionally connected before they have sex, and other people feel emotionally connected from having sex. And so sometimes they end up together, and there's like a standoff. And so one thing I'd like to try right now is to do like a dialogue between you where you actually talk to each other. Because I could say brilliant things all day, which I'm sure I would, but it's not going to help you when you go home. So I want to give you a little introduction to some skills that you can take with you that might help you feel more connected as you lead up to like your sex date night. And then I'll give you some specific things to do on your sex date night if you decide to commit and take on this mission of your sex date, your erotic date, which, by the way, is not a date night where you go out to dinner and go to a movie and eat rich food and drink wine, because no one has sex after that when they come home. Everyone's tired and bloated, and no one likes to have sex.
No,
No, it doesn't work.
let's have wine, drink beer, and
Yeah.
Fall asleep.
I've never been like it's sort of an athletic event. You know,
It's an athletic event. You have to prep.
I mean,
Exactly.
it's different with those guys who went out and played softball and drank beer. I never understood that at all. Why would you do that?
Yeah, so sex and beer and wine, maybe a glass of wine,
Sure.
but not a
Not a
six-pack of
bottle.
beer.
Right.
No.
Not spaghetti. Not popcorn at a movie. So let's do this dialogue I'm going to teach you. And at first it's going to feel sort of corny and stilted and unnatural, because I'm going to have you talk to each other, and I'm going to have you mirror back what the other person says. And I'm just going to have you do an easy dialogue, because a lot of times, I mean, you guys seem to get along pretty well. You're not saying, oh my God, we fight all the time, or we have a lot of stress in our relationship or in companionship. It's more the neglect of this erotic life that's really the problem. It's not really that there's a lot of trauma and betrayal and anger, although it seems like there might be something under the surface a little bit with that pillow in the middle of you. So,
I can get rid of it.
well, we'll get rid of it metaphorically,
Okay.
and you can hold on to the actual pillow if it makes you feel safe. And so when your partner looks at you and says, we need to talk, like I know you guys have talked a little bit before you got here, but sometimes when you get that, like, we need to talk, what happens is it triggers your fight or flight response in your brainstem, and you get a little scared or nervous or angry. You're like, okay, this is, especially in a male-oriented brain, and that's not being sexist, it's just sort of a neurological pattern that happens, where you get defensive, like, uh-oh, am I in trouble? What does she want to say? How am I going to react to this? I have to fix this. And so instead, I'm going to have you start with appreciations, because appreciations will help you go into your prefrontal cortex, where you think more like adults, and you're like, oh, yeah, appreciation, that's good. Like, bring that on. Say more. I want to hear more. So we'll start there, and then I'll help you talk about some more intense stuff. Okay?
Okay.
So you're going to start by looking at each other so you can face each other. I know that's a hard part.
No, that's what I wondered.
Eye contact. You can
Maybe
keep the pillow.
The pillow will be right here.
It's okay.
Maybe I'll switch a little bit.
Okay.
There.
Oh, my favorite.
Hi.
Hi.
Oh. And one of you can be the sender and one can be the receiver, and then you'll switch. And you just think about like 3 things you appreciate about the other person. And it could be anything, like, I appreciate you brought me coffee this morning. And so you might say to Jen, I appreciate you brought me coffee this morning. And then you're just going to say, so you appreciate that I brought you coffee this morning.
Oh, okay.
And that's all.
Okay.
What you don't want to do is say, oh, so you appreciate that I make you coffee every morning and I'm always the one that gets up first. And I always have to grind it because you never do. And I always have to clean up. Like, you want to make sure that you stay with exactly what he says.
Okay.
So it's some task. It's not something broad.
No. It could be something broad. It could be something universal that you appreciate about them or anything.
And then the other person acknowledges that.
Yeah. And then you'll send another one. And then, so do at least 3, and then you'll switch.
You want to go first?
Sure.
Okay.
Jen, I appreciate breakfast you made this morning.
You appreciate the breakfast I made this morning.
Perfect. That was perfect.
Okay.
You got it.
Oh, good.
Yeah.
All right.
So let him send 2 more so you can just sit and bask
So I
in the
don't say it
appreciation.
right away? I say
no,
them after?
you did it perfect.
Okay.
But let him just keep sending you some
keep saying more.
appreciation,
Okay.
and then you can switch.
Okay.
Then you can just relax and receive.
Okay. Okay.
I appreciate that you ironed my shirt the other day.
You appreciate that I ironed your shirt the other day.
I appreciate that you picked up Josh from practice.
You appreciate that I picked up Josh from practice.
And you can ask him, is there more?
Okay.
I'm sure he has a million more things that he appreciates about you.
Okay.
But he might say that's good for now, or he might have a desire to say something
Is
else.
there more?
Of course.
That feels really nice to just even hear him say that. I know he does appreciate it. I just inherently know that he appreciates it, but to hear him say that, it's nice.
Yeah, good. So can you give her another appreciation?
Sure. Let's see. Jen, I appreciate being there for me.
So you appreciate me being there for you.
Can you be just a little bit more specific when you say that? Like, how is she there for you that you appreciate?
For instance, the other day when I was I work out of home generally, but I was at a client's house and I'd forgotten a portfolio that was important for this client, and she was able to break away and bring it to me.
You were able to bring.
Yes.
Tell her what you appreciated about that.
I appreciated that you were able to drop whatever you were doing and bring that portfolio to me at the last minute for that important client.
Nice.
You're welcome.
So see if you got that.
Thank you.
So I appreciate that.
You
You appreciate that I brought the portfolio over to the client's house and dropped what I was doing in order to do that for you.
And I'm going to ask you to add one more thing because it made me feel what? What did it make you feel that she did that?
Oh, it made me feel, wow, safe.
It made you feel safe.
Nice. Perfect.
Yeah.
Is there any more?
Comfortable. Whole. Was not alone. Supportive. Had somebody to support me. Somebody that understood.
I hear that you said that you felt supported, that you felt whole, a lot of other good things, but
I heard him say that you felt comforted
and you felt comforted and you felt safe
and not alone.
and not alone.
Yes.
Nice.
It's almost subconsciously. Now that I'm thinking about it, and it's interesting. It has more effect on me too. More realization, I guess. I'm trying to say.
Instead of taking it for granted.
Exactly.
Yeah. Like, oh, she's just going to do it, or he's just going to do it for me. We don't. We always say thank you, hon, or give him a kiss, and here you go, and have a good meeting. But then it's like just another task, kind of. Again, it just it's just something we do because we're together, we're married, and we love each other. It's kind of like we're taking it for granted.
Yeah, I guess you do, and sort of, to get along. It's natural to do that. But I guess there's a point you can exceed where it becomes maybe not good.
So you're really recognizing how much you really do appreciate those things and what it means to you.
Yes.
Yeah, that makes sense. Are you ready to switch?
You can. I appreciate you taking Josh with you last week to the beach, and Sarah was out, so that I could just have the day with Tracy, and we could just be at the pool and just enjoy the day and just have some girl time.
Wow. You appreciate me taking Josh so you could have some alone time with your girlfriend at the pool.
And I appreciate that you were there when we found out that my brother's girlfriend had to have surgery, and you were there for the kids, and you let me go upstate, and I appreciate that.
You appreciate that I understood when your brother's girlfriend had to have surgery, and I'll let you get away and go upstate to spend time.
And I appreciate that when I have meltdowns and don't know how I'm going to get something done with everything on the list, that you are there to tell me I'll get it done and give me a pep talk and support me.
You appreciate that I understand when you have a meltdown and get crazy, things get hysterical. And I say, that's okay, honey, and it'll be all right, and I'll help you out.
I don't think it's hysterical. No, I get hysterical.
I paraphrase.
I'm joking. I mean, there are a lot of things I appreciate.
Yeah, me too.
Yeah. And should I go on how it makes me feel?
Have one more, or
Oh,
you can
one
tell
more.
them that
And
how that one made you feel. Either way.
And I appreciate that, you've just always got my back. When I'm having a hard time, I just feel like you are always there for me.
You appreciate that that I'm there, that I have your back when things are hard. And yeah, I didn't know that.
And that you're always there for her.
And that I'm always there for you.
Is there another example of him being there for you, that you feel like he's always there for you? Just something small, maybe?
Yeah, I mean, he's a great cook, and I appreciate that, you do the shopping and you make the dinner like 4 nights a week. He says he likes it. He loves doing it. So, but I appreciate that a lot, and so thank you.
You appreciate that I make dinner and shop 2 or 3 times a week. I like knowing that.
So that was really beautiful that you guys appreciate so much about each other. And the thing that I noticed, first of all, you did a great job because you really stayed with each other and tracked each other. Sometimes people can't do that. Even when someone says something good about them, they're like, wait, what? They fog over. They're not good at accepting appreciation or giving appreciation. You guys really stayed with each other. And the reason that's important is because sometimes you need to hear back what you said, because you need to be able to say, well, maybe that's not what I really meant. But you guys were really tuned into each other. And the thing that stood out to me is that you really appreciate the things that she does that make you feel safe and you really appreciate the things that he does that are consistent, that you can depend on him. And that's fantastic that you have this connection in your relationship where safety and consistency and dependent feeling is really around connection in your relationship. But it also says that there's a huge focus on your companionship where you're in that phase of your relationship where you're securely attached, which is great. And at the same time, in order to have really good sex, sometimes feeling overly safe can make you feel parentified. Like it makes you feel like you're a family, which is why you get married, is why you have a family, to feel safe, to feel consistent, to feel like you can depend on each other, to feel like you have each other's back. That's what you want. That's like a perfect partner to have a family with. And at the same time, it can feel totally desexualized because who wants to have sex with their family? That's horrifying, right?
Yeah.
So it's such a dilemma.
Yeah.
Because you're so safe and you're so dependent on each other to be in a safe family. How do you at the same time detach from that, become separated and individuated so that there's some distance between you? Like you have to long for each other in the space in between you. We're attracted to someone over there. When they're sitting next to you on the couch every night, not so much. That's just the nature of marriage.
Right.
It has nothing to do with the fact that there's anything wrong with your relationship or that there's something wrong with your attraction to each other. It's actually the fact that you've become a super good couple. You've done everything you're supposed to do. And now we're going to move you to the next phase of your relationship, which is to actually pull you apart a little bit before you do something disruptive or dangerous to your relationship to break you apart. Like sometimes people have an affair or they start fights or they do something because they feel overly merged and they're like, I need some separation from this. Like I feel overly either stifled or like I feel like you're my mother, you're always telling me what to do. Or, you feel like, okay, we become too much of the same person. Like sometimes you see these couples that are like brother and sister and you're like, well, that can't be very sexy.
Right.
And so you don't want to have that overly merged relationship. You want to be able to have a little bit of space where you're like, ooh, he looks sexy. Or, oh, I'm kind of fantasizing about her. We have this weird thing in our culture where we have this like Madonna whore archetypes.
Oh.
So our wife can either be like a perfect mom and a good wife and, just kind of pure, or there's the whore archetype that we see in porn. She does all those dirty things, and that can maybe be a girlfriend or somebody you have an affair with. But it's hard to integrate those two things into your wife. And we do it to ourselves as women. Like it's really hard to integrate the good girl, bad girl thing when you're a mom, right?
It's almost like different masks that she has to wear and change. Okay, I'm this now.
Yeah.
I'm that now, or this now. Or
Yeah, it's really hard. Like we have one archetype for women, which is Mary, which is the Virgin Mary and Mary Magdalene. They're both named Mary. Like that's it. That's all we have.
Yeah.
And so that's a struggle.
Yeah.
When you're trying to be a good mom and not let the kids hear you have sex.
Yeah, and I worry about that more than he does too. Like, no, like really, I'm always like, the kids are going to come in, that quiet or not now. He's going to wake up any moment, and
Right.
And
God forbid they hear you have sex. It's
right,
like
I know.
trauma. They're going to be in therapy forever. They have post-traumatic stress. But I can tell you,
and they know we have sex.
They know you have sex,
Yes.
and they want you to be an erotic couple. They don't want you to just be friends. Even though they might say, "Ew, that's gross," they want you to be in love with each other. That's important to them. I'm not saying they should have sex in front of you.
Right.
Right.
But they want something more, a little more.
Yeah, it's like Josh will say, "Mommy, kiss Daddy," Mom, give Daddy a kiss.
Exactly.
And I'm like, sometimes it's weird. And I'm like, what? He's like, just, he'll grab my face and he'll say, give Daddy a kiss. And we do. And then, but I've never, I don't know. I've never looked at my role as
That's like-
maybe I'm not feeling sexual.
A lot of mothers shut down their eroticism. Like, we all have eros energy, but a lot of mothers will shut it down into a little box and say, well, I'll take it out when the kids grow up. Sometimes men will split it off outside the relationship, like in porn or something. But it's got to go somewhere. It's if you're still alive, you still have it. So we're going to bring it back into the relationship. So as we saw with Mike and Jen around the appreciation dialogue and beginning to have a conversation around pornography, good girl, bad girl stuff, we begin to look at a different model of sexuality and perhaps around the model of female sexual response. So in traditional female sexual response, there's always been this idea that women can become aroused, have an orgasm, and need a time to recover, which is actually a very male-centric model of sexual responsiveness. So men traditionally feel desire, become aroused, are able to ejaculate, and then their testosterone level drops and they need to actually reboot. There's a period of time before they can go through the cycle again. So that's a traditional sexual response cycle. But for women or people in female bodies, actually arousal needs to come before desire. So to be physically or emotionally aroused, to have some kind of sexual stimulus, and you'll see in the slide, women start at sexual neutral, and they might either seek a stimulus or respond to a stimulus. So that arousal comes before desire. So they get stimulated either psychologically, biologically, they might self-stimulate, but that stimulus brings them to a phase of arousal. And then the sexual desire kicks in. So in other words, you know, I was joking around with them that if you want to have sex with a woman on Saturday, to start on Wednesday. That was the idea that just because you don't feel free-floating desire doesn't mean you can't feel desire once you're aroused. And through desire and arousal, then seeking emotional and physical satisfaction can create intimacy, and then you can come back to sexual neutrality. So the idea is that female sexuality, that model of response, is in responsiveness instead of responding to free-floating desire. Now, that's not true for all men or women. You know, it's a little bit of a misnomer that men wander around with free-floating desire all the time and can get aroused at the drop of a hat. That's certainly not true as men get older. On the other hand, a sign of a high sex drive or a high desire for sex is not necessarily a sex addiction. So I'd like to take that into account for a moment, because there's some confusion around what is sex addiction. And sex addiction is not a true diagnosis in the DSM, the Diagnostic Statistical Manual. So it has not been classified as a true diagnosis. And sex therapists and addiction therapists sometimes differ with sex addiction therapists around this. But sexologists traditionally have what we call a sex positive attitude around sex, and say that a high sex drive should not be pathologized. That, again, going back to that, there's no normal, there's no measure or level of how much sex you should have that's within normal range. And that you can't really be addicted to sex. Now, that doesn't mean that you can't be excessively acting out with out of control sexual behaviors that influence your life in a negative way. And it goes back to this idea of, can we equate sexual acting out with, say, an eating disorder? We talked earlier about sexual anorexia. So would that mean that sex addiction is similar to bulimia, where there's excessive, reckless sexual behavior followed by a cyclical period of guilt and self-loathing and then seeking out more excessive, reckless behavior? Just like in bulimia, with an eating disorder, there's a binge and a purge and then guilt and shame, and then the cycle begins again. It would make sense if those two things were equated with one another, particularly if we're equating sexual anorexia with anorexia for eating disorders. But because sex addiction is primarily diagnosed in men, we don't correlate sex addiction with bulimia or sexual bulimia, because those eating disorders are primarily diagnosed in women. And control and pleasure have to do with primarily female diagnoses. And in the next module, we'll talk more about why that is. The World Health Organization has added compulsive sexual behavior disorder as an impulse control disorder to the ICD-11. ICD-11 is the medical diagnosis. So compulsive sexual behavior disorder is an impulse control disorder where there's a persistent inability to control intense, repetitive sexual impulses or urges, resulting in some kind of recurring sexual behavior, despite negative consequences and receiving little or no satisfaction from the behavior. Now, why it's important to talk about this is because there are symptoms that are similar to OCD and obsessive compulsive disorder, and that out of control, intense, repetitive urge is not really about sex. It's about an impulse control disorder. It's not a sexual behavior so much that is the pathology. It's the impulse that's the pathology. So it's important to not recreate more shame around the sexual behavior. Sometimes we see this in religiosity or in shame-based therapies that are still out there around treating homosexuality. And so we want to be careful that when we treat sexuality, we don't label it as a negative behavior, that we talk about the negative consequences of out-of-control behavior. One thing that might help is to be really clear about the difference between desire and arousal. So just to go back, desire includes the drive for sex. We don't talk so much about libido anymore. Libido is a psychoanalytic term that is somewhat antiquated, but we do talk about like the sex drive, the drive to repeat a behavior, or the instinct. Like we talked about before, the instinct to find food and shelter and the instinct to have pleasure. Desire also includes the expectations around sexuality and your gender role. So if you have a desire to be dominant over your partner, or if you desire to be dominated from your partner, to be in submissive role, that's a role, a gender role, or a gender expectation, or a sexual expectation, or a sexual role, that it's part of your desire. If you have a cultural belief or a value around desire, that to be desire, to have that male gaze create self-esteem, when you lose that male gaze, like getting older or aging out of that feeling of feeling sexually worthy because you're not getting that same feedback loop, then that's also part of that desire loop, and the motivation to create a desire and arousal in your own life begins to change. So let's talk more about specific treatment options. For any of these specific sexual dysfunctions, there are a plethora of options, but now that you're better at assessing, you have some assessment tools to treat sexual issues in relationships, including some direct interventions for sexual dysfunctions and desire issues. You have some communication tools, and you know how to talk about like compulsive sexuality. I think the number one treatment option is always couples therapy. I think if you can bring a partnered person in, then they have a better chance of recovery, whatever they're trying to recover from or heal from. Just to be witnessed, but also to have a partner to help you grow through whatever phase of change and development you're in, there's a better outcome. If they're not in couples therapy because they're not with a partner, you can certainly do this work with an individual. To try to find the psychological motive, in other words, what purpose does this behavior serve? If you didn't have it, what would your life be like? If it was serving a purpose, if it were helping you, what would it be doing? So in other words, I have a gay couple, two gay men. They've been together for about 20 years. He is much older than his partner. He was the primary identified patient. So he came in, he brought his younger partner, and the younger partner said that his older partner had gained a ton of weight and he was no longer attracted to him, and he wanted to go out to bars and be in a semi-open relationship. And the older partner said, I think he's lying. I think it's really because I haven't been able to function sexually as well as I used to. I don't get as hard an erection. I don't last as long. And so we focused on that for a couple sessions, and I asked him, what purpose does that serve in your relationship, if that was to serve a purpose? And he said, well, to be totally honest, if I don't last as long during intercourse with us, then I get to stop, and then he just services me. Gives me oral sex, he gives me a massage, I get like the full treatment. And he said, I really love that. I feel loved, and I feel like he adores me, and I feel like he gives me all this attention, and I don't worry so much that he's out with other people. And that like sort of insight and transparency began a whole conversation between them about what their language of love was, like what it meant to be loved, how they showed love to each other, how they experienced love, and what they were actually each looking for. So thinking about what is the motive, even if it seems counterintuitive, even if it doesn't seem to make sense, can they identify what the motive might be? Now, they might be frustrated with you when you even suggest that there could be some kind of positive motive. So be careful to reinforce that this is unconscious and perhaps counterintuitive. It doesn't really work for them in a positive way. Confronting any cognitive issues. We talked about spectatoring and some of the gender role expectations that people come into the relationship with, what your parents taught you, what might be a cultural thing that you learned from your family. And then what are some of the anatomical medical issues that you might deal with? Pelvic floor physical therapy, Kegel exercises, after childbirth or after surgery, after menopause, when your whole pelvic floor loosens and there can be pain or discomfort. Also the opposite, relaxation techniques for vaginismus or dyspareunia, painful vaginal sex. Using dilators. Dilators are a series of what looks like a dildo. So they start off very, very thin and get to a thicker diameter, and so that your vaginal muscles can slowly respond and relax. to penetration. Sometimes you can do that with a partner. Sometimes you need to do that alone through mindfulness and meditation, or even biofeedback. There are topical meds, lidocaine, and hormone treatments that you can use topically, muscle relaxers, and you can integrate individual therapy like cognitive behavioral therapy and specific sex therapy like the stop-start technique I talked about before. Also changes in diet. I know I'm super sensitive to gluten, and gluten will actually give me flu symptoms, so my joints will hurt, my body will ache, I'll get like urinary tract infections, all kinds of strange stuff happens to me if I eat the wrong foods. And as much as I like to eat cake, it just makes me miserable for days. So a lot of exploration into diet things, yeast and gluten. Sometimes dairy does weird things to people's sexual responses, and can even affect their sexual function. There are sexual medicine functional. What am I trying to say? Sexual medicine functional medical doctors who will prescribe laser surgery, and even holistic doctors prescribe acupuncture for sexual pain and dysfunction. And there is a resource section at the end of this course that you can check out for referrals. For treatment for sex and couples therapy, I really recommend that you do get an assessment by a medical doctor, a sexual function medicine doctor, who knows how to work integratively. In my book, Integrative Sex and Couples Therapy, there's a chapter by an integrative medical doctor who works with a sex therapist, and they talk about how they create a clinic where they work by assessment first with a medical doctor, and then work with a couples therapist, and then work with a sex therapist. That combination, I think, is really important. You know, they can combine things like nutrition, assessment for antidepressants or other medication, and refer for mindfulness exercises, or even holistic alternative treatments like acupuncture. So I think the combination of all those things is important. In the last video that I'm going to show you, I'm going to talk about some of the exercises that focus on things like sensate focus and erotic recovery, which are things that I recommend to my couples. A sex date is something that you choose once a week on the same time every week, whether you feel like meeting or not, whether you feel like having sex or not, whether you feel like you're in an argument or there's something better on television, because it's really carved out as something that's sacred to your relationship. And I explain that in this video. And if you haven't had sex for a long time, I recommend that you follow a 6-week erotic recovery protocol so that you don't just go home and have sex, because if you hadn't had sex for a year, you're not going to. And I don't recommend that because it's a setup for failure. But I do recommend a slow, sensate focus protocol where once a week you learn how to touch and massage and slowly recreate sensual experience week by week to build up that trusting, integrative sexual moment until their desire and arousal can conquer the fear of sexual dysfunction. So I'm going to show you the next clip of Mike and Jen and how we process all the concerns around their sex date and what it might bring up, which is totally natural. That the first couple times it seems like fun, and then all of the regular concerns from your relationship will start to creep back in. Someone will come late, someone will cancel, someone will get blamed, someone will feel like they always have to make it happen. And you'll hear how I integrate the instructions for the 6 weeks to erotic recovery. So I will bring you back to Mike and Jen. This is about an 18-minute clip of our session together. So I want to do one more thing with your dialogue, and then we'll close up and I'll give you your assignment, okay? So can you share one thing I'm concerned about when I think about the sex date, and one thing I'm looking forward to?
These two contrasting things.
Yes.
I say one and then the other?
Yes. She's just going to mirror them back.
Oh.
So one thing I'm concerned about when I think about this sex date, and she's just going to mirror that back. I love the face you just made.
Oh.
You're like,
Thank you.
and she's just tapping her fingers like, I want to hear this.
It's nerves.
Bring it on.
I'm thinking of like what I'm going to say.
Well, one thing I'm concerned about on the sex date is that it's, what's the word? Stifled. Too rigid.
Okay. One thing you're concerned about on a sex date is that things will be stifled or too rigid.
Like too mechanical?
Too mechanical.
And so I'm going to just ask you, wait, before you continue, can you just validate and empathize? Like, that would sound like, and you don't have to mirror this part, Mike, but just, it makes sense that you would feel that way, and because why?
Oh.
And you don't have to agree.
Oh, okay.
But you're just going to his side of the couch and knowing him the way you know him, that, why do you think he might feel that way?
Okay. Because I understand how you'd feel that's stifling and rigid, because you're very spontaneous and you're not one to kind of pre-plan, and you don't really like to not be told what to do, but following a plan or a schedule is not something that you like to do. So I can understand why having a set time would be rigid to him. Stifling.
Yeah.
Like that he can't be himself.
Yeah. Okay.
That's pretty good.
Okay.
She sounds like she knows you pretty well. Sounds like it might bother her a little bit, but we can talk about that another time. And what's something that you might look forward to about the sex date?
I would be looking forward, well, in general, having sex. I
Okay.
being intimate,
So you
getting comfortable, being that give and receive, all those things you feel,
All those things I'd feel.
I'd feel.
And then should I respond to that? Like, I can understand why.
Well,
you
first
feel
mirror him.
You look forward to having sex. You would look forward to the date because you can have sex. That you would feel comfortable. You.
You can ask him.
What did you say again? What were some of the things?
The give and take, the
The intimacy.
intimacy.
The intimacy and the give and take of it. He would be looking forward. You would be looking forward to.
Mm-hmm.
And what makes sense about that?
And I can understand that because he is a very sexual person, and he enjoys having sex. And I think that sex does make him feel comfortable because I think it makes you feel wanted and loved, and so I can understand. We haven't had it for a while, so it's something he enjoys, and he's looking forward to that.
Yeah. Good. Yeah, he must miss that. It sounds like he misses you.
Yes.
And he misses me.
Yeah. Sometimes it's like a language of love. So when someone doesn't want to have sex, it can feel like not just you don't want to have sex, but you don't want meat.
Right.
You don't love meat.
Yeah.
Yeah, that makes sense. Are you ready to switch?
Sure.
And
Something I'm not
looking forward to.
or something I'm a little worried about or concerned.
I'm a little worried about the awkwardness of like a set time and day to have sex. And I'm just concerned we both may kind of talk each other out of it in a way. Just make a pact that we won't tell you. But that's like a really irrational like concern. Like it might be awkward to start, but I know that once we get going, we're gonna be fine.
Can you mirror all that, Mike?
Yeah. You're afraid that our sex day will be a little bit awkward, and that maybe we'll put up walls. It'll be not, it won't flow naturally, and that it's like a prescription, like, well, okay, we did our routine and we did what she said, but it wasn't as natural as it should be.
Be forced, sort of.
And you'll make a pact not to tell me that you didn't
that's
do
only-
it.
That's like really irrational fear.
Because we are partners.
You're already closer as a result of this session.
We can do it.
We're teammates.
Yeah, we're teammates. Yeah. And what I'm looking forward to is, I'm looking forward to the intimacy. I'm looking forward to like being excited to be with you. I'm kind of like excited for us to like start this because it seems like something fun and new and yes, like out of the routine, and get our heads out of, like you said, like the coupledom, the parental thing, the stress, the obligations, the everyday that we have.
Let's see if you got that.
you're looking forward to our sex day because of the intimacy and what it is, and that it is outside of the routine of family and, so, what a couple does to support each other, and it's back to the roots of what attracted us to get to each other. And just the excitement of desire.
Yeah.
And what makes sense to you about that?
What makes sense? Well, gee, all of it. I agree with it. I understand what you're saying.
Because?
Because it's true.
Well, knowing her the way you know her, if you were to go to her side of the couch, what makes sense about it that she feels that way? Because you're validating her experience and empathizing with her.
This is, this is difficult because I understand that completely.
Because you...
I'm not sure what words we're looking for, because I almost feel like I'm repeating what you said. That's what I would say.
Well, so let's do it a different way. So maybe focus on the empathy. So in other words, I imagine if we did this, it would make you feel what? Throw out some feeling words that you imagine it would make her feel.
Oh, it would make you feel loved, appreciated, wanted, desired, validated.
Yeah.
Does that make sense?
Yeah, let's ask her. Does that make sense?
Yeah.
Do you agree with all those?
Yeah.
Would it make you feel other things?
Yeah, it would make me feel appreciated and wanted and loved. Yeah.
Good. Good. I think you got it. Yeah, it's interesting for both of you that, to reconnect again sexually would make you both feel loved, that you're both kind of missing that piece of really feeling loved by the other person. It's not that you don't know that the other person loves you, but there's a missing connection of really feeling that action of being loved. Like love is not just something that floats between you, it's the extra action of showing up and loving each other. And that it's really super important for both of you. Like there's an extra layer here that is going to take some action. And that's really what that sex date is. It's the showing up for it. It's kind of like a sacred commitment to your relationship. It's like meditation or yoga where you commit to that part of your relationship because it's sacred. You carve it out. An hour a week. It's like you turn off the TV, you light some candles, you put on music, you show up because it's the commitment that you make to that part of your relationship that is not like the rest. It's different than everything else. And there is something really sacred that brought you together. There's some kind of bond there that is loving in a different way.
Special.
It's special. It's really special. It's very sacred. And for the two of you, I don't want you to have intercourse for the next 6 weeks. So I'd like you to you can cheat, you can come back and go, Dr. Tammy, we were bad.
I'm not going to say anything.
That's okay. Sometimes it's forbidden, makes it hot. I get it.
Right.
What I would recommend, because sometimes it's awkward to just say, okay, go have sex. You haven't had sex for a year. Like, it's kind of like, okay, just take off your clothes, let's just do it. Like, that's weird.
Yeah.
So I'd like
Work into it.
Yeah, work into it, work up to it. It's kind of in a sensual, connected way. I have a 6-week erotic sort of protocol. I'm going to send it to you.
Okay.
So you can take it week by week, but this is basically how it goes. You're going to do massage at first. So regardless of how you feel about massage, the whole idea...
I like it.
Okay, good. The whole idea is to be the giver and the receiver and to take turns. So the first week you can give her a massage. Let her just go to sleep. No penetration, no orgasm, just, no bikini areas. Just let her fall asleep. She's very stressed. She's got a lot on her mind. She's got a lot going on. I don't even know if she realizes how stressed out she is. So just give her a massage, light a candle, give her a massage, let her fall asleep. That's your first sex date night. The next week, you do the same for him. Give him a massage, let him fall asleep. No orgasm, no penetration. And then the third week, massage, you can give her an orgasm, but no intercourse, no penetration. And then the next week, same for him. You can give him like a happy ending. And massage.
God, great.
I know what you mean.
But no intercourse. And then the following week, still do the massage, light the candles, make it special. If you want to have intercourse, that's okay, but I prefer to just continue with this idea of expanding on the orgasm, make it a little bit more special with some direction. And then the following week, the same for him. And then by then, you should have this awareness of like, what does it feel like to receive? What does it feel like to give? Because you're going to notice in your head, well, how come he's not doing it for longer? How come she's not doing it harder, faster, softer? Like all this noise in your head around your relationship stuff is going to come to the surface, and you just notice it. The thing that also happens is by like the third week, you'd be like, well, how come he's always late? How come I always have to remind him? Or how come she never shows up when I tell her to? Or like all that stuff from your relationship is also going to happen, and just do it anyway.
Okay.
Just do it anyway. Meanwhile, we'll meet again. We'll talk next week about how it's going. Even you'll have time, next week, so that'll be 2 weeks. You'll have time for 2 sex dates. And we'll talk about how it goes. We'll talk about if you show up, if you choose to even do it, and how it goes. There's no right or wrong way, even if you fumble and it doesn't work or you get busy or whatever. The idea is to really just commit to the relationship. Okay?
And as far as like getting the massage oils and the candles and all that, is that we can discuss that and talk about it, or is it because the date night and it's his? Is that his responsibility for the first one and it's mine?
So
the
it
next?
begins. The negotiation
So the first
begins.
night, I give her a massage.
Yeah,
Right, but I'm
She
like,
goes to sleep. That's it.
that's it.
right.
The next time, she gives me a massage.
Exactly. So
And then we come
maybe
and see you.
exactly. So maybe you want to talk about that. Your assignment is really to pick the date and the time. That's the hardest part, to get it on the calendar. And then maybe the next part is like, who's going to get the massage oil?
Okay.
Yeah, we can do that.
I know that's not a big deal, but I was like,
Oh no, apparently it is a big deal because you thought about it. It was the first thing you thought about. So it's already kind of a little bit stressful.
yeah, because I'm like thinking,
It's a responsibility.
Is he going to get it? And
Yeah, I totally get it. So
There's stuff around.
So let's close. Let's close today by just saying one thing you appreciated about each other for today, and just mirror that back.
I'll go for.
Okay, go ahead.
I appreciate how open you've been, and how easy you've been.
You appreciated how open I was and how easy it's been.
Nice.
I feel like I would say the same for you almost, but I don't want to repeat your words. I think, I appreciate how honest you've been, and it was almost, it was enlightening.
You appreciate how honest I was, and it was enlightening for you,
Almost surprised.
and almost surprised.
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 I have.
He was surprised.
It was a little passive aggressive, but that was nice.
I am surprised that we didn't have more like resistance towards to this whole thing,
Yeah.
which makes me feel like we're both on the same page. Like we both want to help.
Oh, you mean once we're here? Yeah.
Yeah.
Yeah, so
Yeah.
you're surprised that there wasn't more resistance from both of you, so that gives you hope that you both want this,
Right.
and you're both going to work towards
Yes.
it.
Cooperation.
Yeah. And you really cooperated.
Yes.
Well, you guys are definitely a team. So what I appreciated is that you're both definitely a team, and you're working on this together, and you are committed to going forward.
What? Why are you laughing?
Oh, I'm not laughing. I'm smiling. It's
Yeah.
happy smiles.
Yeah.
So who's going to pay for today?
Well,
Well, since you initiated it
I think-
with her.
Jen has a checkbook.
But I have the checkbook, so I will pay for today.
And so we'll make the time for the next time we meet, and I'll see you guys in a couple weeks.
Okay.
Did a great job.
Thank you.
Sounds good.
Thank
Thank
you.
you.
See you next time.
Okay. Bye.
Thanks.
So with Mike and Jen, you can really see how that sex date has become and will become an important part of their healing. That assessment, that intervention, and that ongoing work on their relationship really creates a positive treatment outcome because we can talk about it in the session, they practice it during the week, and we slowly integrate all of the things that we work on. I can't help them if they don't practice it on their own. So in Module 2, we're going to focus more on really working interventions, dialogues, more appreciations, how to stretch and repair, how to soothe, deal with the triggers that come up, and focus more on healing from what I call pleasure disorders and focusing less on performance. So once we get comfortable in the psychotherapy part of couples therapy, we work through the performance fears, now we can really focus on moving into pleasure. So let's just review some important pieces here of treating sexual issues. I think it's super important to work in an intersectionality way so that we are not only focusing on how culture has brought us to this place and the needs of feminist idealism around what is sex and what does it mean to women and how did we get to this place, and are we coming into our relationship from a balanced partnership place, or are we coming into our sexual dilemmas from a place of power and control? And how do we have those conversations in a psychotherapy session when it's really a triad that is almost a setup for aligning with one person or the other? So we're really out of balance, out of control. And it's a power imbalance from the setup, from the get-go. So how do we have those conversations? We'll talk more about that in Module 5 as well. When we also talk about how race and people of color and other background cultural issues have intersected with our own history. Like, where do we come from? What is our background? I found out very shortly before I went to Romania to do my TEDx talk. I was going to Bucharest, that I got my DNA results back. And it showed in my DNA results that I was 30% Romanian, which I had never known before. No one had ever told me that before. I knew that my grandfather had come from Russia. He was actually Ukrainian. And so the area of Ukraine and its area of Romania are apparently very close to each other. And when I went to Bucharest in Romania to tell people that, oh my God, I think I'm Romanian was a big thing. And we got into this discussion several times around how uncommon it was for people to go from Ukraine to Romania, that most people were escaping Romania at that time to go to the Ukraine. And that most of the travel between those two places at the time was with through people who were gypsies. And I thought, well, that was kind of cool that I was a gypsy. And when I said that, you could hear a pin drop in the room. Like that was a cultural no-no that I said that. That was like really, people were embarrassed. They walked out of the room. And it was a racial issue, not just cultural, in that part of the world. And I, for the first time as a white woman from America, experienced some of the racial issues that I realized that people of color in this country have always experienced. And even though it was just a small little tidbit, smidgen of prejudice that I've never really honestly experienced before, I just got a tiny glimpse of what it must be to have that experience for your whole life. And so we can't ignore what we bring into the room, whether you are a middle-class, white, privileged adult therapist, whether you come from a racial background that's different than your clients, whether you have a cultural challenge out of ignorance of other people's experience, whether you're trying to have a contemporary view of today's clients. I think it's important to have the conversation because it affects today's couples and today's sexuality. We also have to have a conversation around gender. We are in the world of Me Too and Time's Up, and we can't ignore that conversation. We can't not have that as a thematic background in the world of psychotherapy with sex and couples therapy. And so you don't have to have an opinion in the room with your clients, but you have to have knowledge of your own feelings and your own experience around the Me Too issues and the Time's Up issues in your own personal life and in your own countertransference to other people. And so we will talk a little bit more about that in Module 5 because it's an area and a directive in the contemporary world of psychotherapy and couples, in the world of couples. And the model of sexual wellness that we're going for is that there really is no normal, that there is no normal. Normal is a setting on that washing machine. And that we're going for integration. That integration means integrity. It means integrating all the parts of you. It's the opposite of compartmentalization. Compartmentalization means there's parts of you that you feel you have to split off and hide. It's the part of you that something happened to you traumatically that you have frozen in your past and you feel shame and guilt around and you can't integrate it into your experience. So when it gets triggered in a sexual experience, you freeze. You leave your body. You spectator. You can't relax. You feel traumatized. You can't soften into pleasure. Integration means learning how to bring all the parts of you into your relationship and to feel accepted and loved and wanted for who you are. And that's the goal of sexual wellness. The third goal is individuation. To be able to want what you want, to desire what you desire, to have fantasies about what you fantasize about, and to want whatever it is that you want, even when it's different than your partner. So just like your partner might want pizza and you might want Chinese food, we all have different desires and different hungers and different longings, and that's part of being an individual. That's also the thing that makes you long for and desire and be attracted to someone else. And the longer we're together, the more disturbed we are by our partner's individuation because it feels more and more threatening. We like it in the beginning, and then the longer we're together, the more difficult it is to deal with. So how do we support our partner's individuation at the same time that we long for our own without pathologizing it? So sexual wellness is a way of supporting each other's individual growth and at the same time helping our own longing for connection by staying individual. And then the last part of sexual wellness is pleasure. owning your longing for pleasure, understanding that you deserve pleasure, and understanding how you might be trying to control pleasure in your own life and turning it away. So there's no normal, integration, individuation, and pleasure. You know, most people find what they like in bed and then they repeat it, sometimes for years. And so moving out of your routine is a way to decrease long-term boredom. But there's a power struggle in our sex life. Like, we learn how to push each other's buttons because it works and we like it. And so we'll do what we like over and over because it's great. But sometimes you have to try something new. You have to push the edge. You have to add adventure. You have to add something unique, while at the same time being exclusive to your partner. Sometimes that is a real challenge. And low desire can sometimes mean that it just takes a little extra effort, but sometimes it might mean something else. You know, sometimes we proceed as if low frequency of desire is evidence of something pathological, where it might just be evidence of good judgment. It might mean that the sex is not working. And the more often you have sex that's distasteful, it acts like aversion therapy. So our desire dysfunction is really about disappointment. You know, frequency often becomes a conversation instead of the quality of sex, which is really the problem. So when couples can't communicate, they may keep having the same sex over and over, even if it's not rewarding. So maybe we shouldn't talk about frequency as much as whether the sex is good or rewarding or not. And that's what we're going to talk about in Module 2, sex therapy for low sex or pleasure disorders. And in this final slide, there's a guy standing by the bed who says, I really think you should see a specialist about your lack of libido, Sharon, who's making absolutely no effort to make sure that sex is pleasurable. So I want to thank you all for joining me for Module 1, Assessing and Treating Sexual Issues. If you have any questions, you can contact me at tammy@drtammynelson.com. For more information about being a certified sex and couples therapist, go to istitraining.com, ISTI training.com. That's the Integrative Sex Therapy Institute.